I would like to invite Dr. Emma Hane. Dr. Emma is the Chief Access Officer at FIND. Emma is a public health doctor. Dr. Emma supports FIND's efforts to expand access to effective diagnostic testing. She has been leading FIND's COVID-19 response, including the creation of the ACT Accelerator, that is the Access to COVID Tools Accelerator, in which FIND is the co-convener of the diagnostics pillar, along with the Global Fund. Emma holds a medical degree from the University of Auckland, New Zealand, and has a Master's of Public Health from Harvard University.
Fantastic. Thanks very much, Sanjay, and thanks all for coming down today to talk about the space that has changed so rapidly in the lessons that we've learned from COVID, I think, which diagnostic testing is. I think never before have we been in a situation where your aunts and uncles and grandmothers could lecture you on the performance of different diagnostic tests and weigh up the benefits of PCR testing versus rapid testing. We're in a moment for diagnostic testing right now, and to be able to realize the benefits of that for wider public health, for wider health outcomes, I think is part of our aims as FIND, and I think links very much to the topic of how do we continue to build resiliency in some of the health systems, some of the countries that we work in. I'm going to touch very briefly on FIND writ large. You're going to hear later, as Sanjay's talked about, from other speakers about the situation in India, about some of the sort of collective work, and then together I think we're going to have an opportunity in some of the panels that come to really be able to advance thinking about what does it mean to take some of this great technological leap forward through into people's homes, into people's healthcare. So briefly, as background for you for FIND. So FIND is almost 20 years old and was established as a product development partnership to solve the gap on innovation and R&D for diagnostic testing for key global health diseases. FIND in India is actually about the same size as FIND in the rest of the world, which I think speaks to the critical importance of India, both in terms of solving some of public health's biggest challenges in areas like tuberculosis, as well as being a real center for R&D as a hub. We collaborate very closely with a number of stakeholders, including WHO and our WHO collaborating center as well. And FIND has pretty big ambitions when it comes to what diagnostic testing can do within health systems, including the effects that we've seen around how more timely testing closer to people's homes can really make a difference in terms of lives saved, in terms of money saved for healthcare budgets and for individuals, as well as, and we're all familiar with this in the context of COVID, how powerful diagnostics data can be in driving and informing a public health response. I'm going to just touch briefly on some of the trends that have happened in diagnostic testing and what they mean for us to help sort of set the stage for some of the conversations that will be to follow. So pre-pandemic, what kind of situation were we within health systems in general? So most of the time, there was very limited testing that was available at home in most countries. There was some basic testing available at the primary care level, but by and large, most testing was concentrated in hospitals, laboratories, and in reference centers. And this remains true in most countries, in most low middle income countries, and here in India, where there's been multiple surveys of facilities on availability of basic diagnostic testing. And what you tend to find is really large variance in availability of testing from some states and some health centers with comprehensive packages of diagnostic testing to others with really significant gaps. What we've seen through the COVID pandemic is huge advances in the innovations that have been available. So diagnostic testing has moved from laboratories through to people's homes, where you can now, and many of you would have done, be able to do diagnostic testing in your own bathrooms or in your own kitchens. We've seen a lot of miniaturization and simplification of laboratory testing to mean that tests can now be moved to the primary care level, and advances in technologies which had previously been research only or frankly, space age and cutting edge, moving down into laboratory systems. In fact, India was the second country in the world to receive WHO pre-qualification for a rapid test for COVID with PMC. So we've seen India play a really critical role in advancing this technology pipeline and moving technology down closer to where people are. What do we think will happen in the future? We think that this trend will only continue. We see a huge pipeline of promising technologies which could really radically change the way that diagnostic testing works throughout the systems, both in people's homes, where we see further advancing of self-testing and home-based testing, the continued availability of better, simple and cheaper miniaturized testing at the primary care level, as well as advances in the testing that can be done in laboratories that has moved out of research and academic settings into standard practice. If you think about areas like genomic surveillance, which were previously heavily research-based, but are now become much more common practice in laboratories throughout India and throughout the world. Just focusing on the technology and the products alone, however, doesn't really capture all of the changes that we've seen in the technology space, driven heavily by COVID. What we've also seen is huge advances in digital innovations which support diagnostic testing. And here, India has played a critical leadership role, both at the state and the national level, in using digital innovations and digital tools to help support the COVID response, coupled with diagnostic data. That's included digital tools to help empower patients to provide better knowledge about health status, about how to manage their risks of COVID-19. It's supported healthcare workers with tools to be able to help support better clinical decision support, and also to be able to inform the public health response, to be able to collect real-time data on the prevalence of COVID, to be able to help public health officials and others to be able to drive a more effective response. And here we've continued to do a lot of work in India as well as elsewhere to be able to help build out this toolkit. This toolkit doesn't currently get applied through other diseases where, for example, in tuberculosis, you might wait 2 years to know what the prevalence of the disease was this year. So how do we bring that just-in-time element provided through digital tools in the context of COVID through to the other diseases that are of significant public health concern here in India? I think talking about the advances wouldn't be complete until we also touch on the question on genomic sequencing, which has been critical for tracking the spread of new variants as they emerge. And what we've seen globally is a radical expansion in sequencing technology availability and the amount of genetic sequencing that has been done on COVID to be able to track these new variants. Whether the expansion has been enough to capture the extent of the challenge that has been posed by COVID and others, I think is an open question. But there is therefore a significant new resource base available for genomic surveillance that can be applied across other diseases like tuberculosis and influenza and others, where genomic surveillance had previously been a long-term priority, but is now a more immediate possibility. So the technology looks amazing. What does it actually look like in terms of access for patients, for healthcare workers, and in clinics? And here the picture is much more mixed. So what you can see on the right here is a graph of testing rates by different income classification for countries. And you can see the significant testing inequity that has grown over time, not shrunk, between high-income countries and low-middle-income countries. India actually sitting at the top of the list on low-middle-income countries here. But there are certainly countries that test at 100 times lower rate than the high-income country average, which means, to repeat a common phrase, if we're all not safe until all of us are safe, then there is significant challenges that are still posed by COVID and other viruses and other respiratory pathogens until we're better able to realize better diagnostic equity for all. One key part of the equation is manufacturing of diagnostic testing. And we at FIND have done considerable work to expand manufacturing for diagnostic testing which has previously been heavily concentrated in just a few low-cost, high-volume manufacturing countries globally. This has included, as I said, the work to help bring the first pre-qualified rapid tests outside South Korea through India. But I think that's really just the start of the potential for India to be able to be a really manufacturing powerhouse in the space of diagnostics. This is important for a lot of reasons. I think it allows for more appropriate, relevant tests for local markets. It helps us to be able to realize better testing innovation for key global health diseases, which may not be priorities for companies based in the US or in Europe, but would be priorities for companies who are based here in India, and allows for more resilience in the manufacturing supply chain. I think this applies both on the manufacturing side, but obviously also on the R&D and innovation side, where India has played a key role, especially in advancing some of the newer technologies like CRISPR through to market. I've touched on this before, but I would say, testing had previously been, as we've said, really the purview of laboratories and hospitals, and we've seen testing move much further throughout the system. And that's included testing in people's homes, the role of testing for workplaces, for schools, for large events, for testing for border entry. And in all of these settings, this is really a novel setting for us to be able to move diagnostic testing to, and it brings with it both challenges and opportunities. We've been collaborating heavily here in India with USAID on testing in garment factories to be able to help the economy reopen safely. And I think when you think about other diseases that also have the potential for spread like tuberculosis, like influenza and others, how do we bring some of those lessons from COVID about testing beyond the health system through into regular practice for other diseases? Because health is not just the business or interest of those of us who work in the health system. I think health is really the interest for all of us. The connection between health, economic development, defense, and other sectors has never been as clear as it is now with the COVID pandemic. So that's all I wanted to touch on more broadly about some of the more global level thinking around where diagnostic testing is going, and hopefully it's a helpful setup for us for some of the conversations to come. Thank you.
Thanks, Sanjay, and a warm welcome to all of you. I'll briefly take you through FIND's work in India. I think Emma's already alluded to this slide, but I would just like to focus on the last part, which is our 2021 strategy, which focuses on saving over 1 million lives, over $1 billion in healthcare costs, and also empowering countries in this process with diagnostic data to inform policy and care. Our strategy actually alludes to making global efforts towards universal health coverage and health emergency response, which are two sides of the same coin. And in this, in the universal health coverage, our goal is to actually expand the primary care to combat diseases, especially focusing on the vulnerable population. Under this, we include TB and hepatitis, screening for antenatal, for communicable and non-communicable diseases, and reducing the effect of undiagnosed fever and pneumonias amongst children and other vulnerable populations, while also looking at some neglected tropical diseases. On the other hand, to mitigate the health emergencies, we are looking at strengthening the pandemic preparedness, building on the broad COVID-19 testing capacity and the ACT accelerator, which I'll mention a little later in my slides, while also addressing the silent pandemic of antimicrobial resistance to, for testing and surveillance and to safeguard drugs and reduce mortality. While we are serving the diseases and populations, we are also working towards strengthening the diagnostic ecosystem. And under this, we are working towards deploying digital tools which unlock the power of data, strengthening diagnostic network design and optimization, which gives an opportunity to use the local data to develop contextual and locally acceptable strategies, fostering a network of integrated biobank network, and also shaping markets so that we have quality assured, affordable diagnostics available for the most needed populations. We are also working towards strengthening genomics and surveillance, genomic surveillance through sequencing, which is the future as we see. What has been Find India's journey? So having been established in 2007 through an agreement with the Ministry of Health and Family Welfare, we started our work through in-country evaluations and demonstration. By 2012, we had expanded our work, and most of our work at that time was in TB through Expand TB and Global Fund supported projects. And we helped establish 12 state-of-the-art biosafety level 3 TB labs. By 2015, we increased this number to 46 labs across the country and also forayed into the private sector through a USAID-supported pediatric TB project, which helped increase diagnosis amongst the pediatric population and also strengthening the availability of upfront molecular testing in this vulnerable group. By 2018, we further expanded our TB work. We added lab information management system, strengthening the EQA systems, and also helping the TB labs to achieve ISO 15189 accreditation. One of our landmark projects called the Project G, Joint Effort for Elimination of TB, was started in 93 districts in 2018. We also started our work in hepatitis C through the Head Start project and collaborated with ICMR to initiate a study through the AMR Accelerator. More recently, by 2021-22, we had established 68 labs across the country. We also started our work in diagnostic network optimization and also initiated addressing the large burden of latent TB infection in the country. We also completed our Head Start project and the microelimination project in prisons related to addressing the HCV problem. The AMR continues in collaboration with ICMR. We also worked in strengthening the COVID response through capacity building, diagnostics, and testing support, and also started our work towards health system strengthening. Coming to our TB work, which you'll appreciate is our most prominent and the largest bucket that we have. We have three main pillars here. One is that we are working towards strengthening the lab network. And like I said, we've already established 68 state-of-the-art biosafety level 3 culture and DST labs. The impact of these labs has been that till now, over 3.2 million patients have been tested, and we've facilitated diagnosis of over 150,000 cases of drug-resistant TB. Over 1,000 gene expert sites and more recently TrueNet sites have been included in the FIND's quality assurance programs. And we've also strengthened the genomic surveillance for TB through establishment of 6 labs across the country. Private sector remains a big challenge, with notifications not happening, patients not being offered treatment adherence support. To address this issue, FIND, along with other partners, initiated the joint effort for elimination of TB across 93 districts in 6 states. And we provided sensitization and training to over 40,000 private providers. We notified nearly 200,000 patients, which meant an increase of notifications from the private sector by over 3 times. We also supported these patients in treatment completion and achieved an unprecedented successful treatment outcome rate of over 82%. Remember that there was no measure before this project on how many patients were actually successfully treated in the private sector. We are also now in the process of setting up DRTB centers in the private sector where still over 50% of the TB patients seek care. We have also decentralized and started working in the community, and to address the India's large latent TB infection burden. Nearly 40% of the Indians are actually suffering from latent TB infection. We are now reaching out to the household contacts of pulmonary TB patients. And through this project supported by Global Fund, we intend to reach out to over 450,000 TB contacts and put them on TB preventive therapy by March 2024. We are also developing the capacity of TB survivors, who have a major role to play since they've suffered from the disease and all the challenges that the disease brings along. mentoring them into TB champions, and then leveraging their services for helping the TB patients complete their treatment. Find also implemented a USAID-funded novel pediatric TB initiative from 2014 to 18. And in this, nearly 100,000 children across 10 Indian cities were offered upfront molecular testing, resulting in diagnosis of over 6,000 patients. This project had a huge impact, and the main achievement was that it was instrumental in the formation of the Indian national policy for diagnosing children with upfront gene expert testing. In COVID-19, we had a huge portfolio, starting from independent evaluation of COVID tests, which was done across 3 trial sites, and we also conducted an operational feasibility of our in-country Tata MD check test, which was based on CRISPR technology. We also supported strengthening the testing capacity through provision of critical diagnostic equipments, RT-PCR tests, and this was the time, when RT-PCR tests were in short supply, and there was a huge demand both in country and globally. And also personal protective equipment to over 20,000 lab staff. We also worked towards strengthening the India's lab capacity by training lab personnel across both public and private sector COVID-19 labs, which were approved by ICMR. We did an upskilling refresher training of over 1,400 lab personnel, and also set up a chatbot for online expert query support. We also worked with the Municipal Corporation of Mumbai in a unique project which strengthened TB COVID bidirectional screening with some encouraging results, and now that is being sustained by the Municipal Corporation of Mumbai and also being expanded to other municipalities as well. We also evaluated some use cases around COVID antigen tests in general OPDs of hospitals to demonstrate, how best we can open up the non-COVID health services. Antimicrobial resistance is a big challenge in India, and by 2030, it might be one of the leading causes of morbidity and mortality. So in collaboration with ICMR, we have started a study through the AMR Diagnostic Accelerator, which is being implemented at 4 sites across the country. And the main objective here is to assess the impact of use of commercially available rapid diagnostic tests on use of antimicrobials for treatment of febrile patients who present to the primary healthcare facilities. Out of the 10,000 sample size, we've already enrolled 5,000. The study started in September 21 for a duration of 1 year. And we are also looking at how COVID-19 has actually impacted both the diagnosis and management of febrile illness amongst children, adolescents, and adults. Find India also started a flagship program on hepatitis C virus screening and testing. And amongst the key populations in India, we were a lead on the hepatitis C virus project, which was funded by UNITAID. And in this, we implemented some innovative models for screening and treatment of HIV and HCV co-infected and other high-risk patients. The project actually led to screening of over 75,000 people with over 9,000 cases detected. And amongst this, more than 5,000 patients were linked to treatment. If you look on the table, if you look at the table on the right, this actually has led to a significant impact, both in terms of averting deaths, DALIs, and almost a $4 million savings to the health system. This actually translates into a 3 times return on investment. Find also initiated a project for screening HCV amongst the prison inmates, where the HCV prevalence is quite high. And this was implemented in 3 states, Punjab, Haryana, and Chandigarh. And in this project also, we have screened till date over 30,000 inmates, confirming nearly 2,400 HCV patients, and out of which 90% have been initiated on treatment. The ACT-A Accelerator, which was initiated by WHO, has 3 main pillars. The vaccine pillar, which is convened by CEPI and co-convened by Gavi. The therapeutics pillar, by Therapeutics Accelerator, supported by UNITAID. and the diagnostic pillar, which is led by FIND and co-convened by Global Fund. Under this pillar, under this ACT-A accelerator, we have supported COVID-19 interventions in India as well. We've enhanced testing capacity at 8 sites across 6 states through supply of critical equipment, including RNA extractors, RT-PCR machines. We've also, in collaboration with IGIB, set up the first of its kind micro labs for strengthening the genomic surveillance. 3 such labs have been set up with very encouraging results. And we are also studying best practices for opening up workplaces by promoting self-testing using the rapid antigen testing kits in 2 factories in Bangalore. I would like to take this opportunity to mention and thank all our partners with whom we work and for their trust and confidence that they place in us and the support that they provide. And we look forward to continuing this relationship and even strengthening this further. Thank you so much. I would like to welcome Dr. Sapna Poti, Director, Strategic Alliances in the Principal Scientific Advisors Office, Government of India, for the keynote address.
It's very easy to find FIND, especially when there is Sanjay behind it. He's so persuasive that you can really not avoid him. Thank you, Sanjay. So I'm not sure how many of you have actually seen the puppets in Nepal. Any of you? Masks or puppets in Nepal? Great. So have you seen that there's a black and a white in most of the masks? Basically, it predicts that you have negatives and positives in every person, as well as in every activity, intervention, and a pandemic. So it all depends on you as an individual, that what do you want to focus on? Or as a nation, on what do you want to focus on? So from the Office of the Principal Scientific Advisor to the Prime Minister and to Government of India, the Strategic Alliances Division focuses on the positives. And we think that it's very essential for us to encourage stakeholders who also align to this kind of a perspective in life, where we are most optimistic, and especially when we are in the lower phases of life, because it's very easy to sail through when it is a good phase of life. So my division, which is the Strategic Alliances Division, actually came up during COVID, and I was, of course, alone in 2020 when I was invited from IIT Madras to head this division. We had literally no clue on what needs to be done in a pandemic. That was our first time, and we did it famously well, only because of the stakeholders and partners that we worked with. We worked with about 200 of them, and they were mix of global and Indian partners. I'm really not sure how this magic happened and how fast it happened and the kind of role that the office could play to get the best strengths out of each of these stakeholders. It was literally like a direction of a play where all these players were doing a good job, and we were just there behind them and supporting them as and when we could, and humanly so, because there were times when we broke down, there were times when we had difficult moments as well with each of the stakeholders. But I think the outcome has been absolutely awesome. In terms of what are the lessons, I don't think I'm here to give lessons, but I would just like to say what are the kind of impact we managed to make out of this pandemic, and which are permanent in nature. It's not only related to COVID, right? So, and that also happened accidentally. It was not that we had made a big plan of, okay, this would be the permanent features that the nation would have ultimately after this pandemic, etc. It was really not like that. It was just accidental, but we're very happy with the outcome that has come about. The first one would be indigenization, indigenous development of raw material for some of our products. And we had CCAMP, NCBS, the Life Sciences Cluster of Bangalore, CCMB, IGIB, who worked together with our office to develop reagents. Those days, most of you would be aware that reagents were actually being imported from Korea and they were not working. So this life sciences cluster came alive. Rockefeller Foundation funded this entire project. They even provided a whole project management unit because they realized that we didn't have enough resources in the office. And we developed these reagents where we did the research and development through the life sciences, and then we had the whole host of MSMEs working on the manufacturing of those, and a lot of organizations like the Tatas and the Biocons buying some of these. So the whole value chain of the reagents development was done very easily and very well. Easily because these stakeholders did not let us know that there was a lot of challenges behind it. Second one was on zeolites, because again zeolites was being imported, and most of the funding of the CSR or of philanthropists was actually going in importing and flying down the zeolites, and it was quite a fad or a statement that we flew down zeolites from XYZ country, which was great at that moment, but it showed that the nation is not ready. So we also focused on development of reagents. And some of the South Indian manufacturing organizations came forward, and then they said that they have the know-how, and Tata Chemicals supported that know-how and so on. So zeolites was the second part of this indigenization that we're talking about. The second major aspect that got a focus or an impact was manufacturing in scale, right? So we did something called the O2 for India, which is a consortium of oxygen concentrator manufacturers and PSA plant manufacturers. So they came together during this time. So we had two committees which were screening some of these manufacturing MSMEs and startups, because zillions of them mushroomed. You know how it is, right? I mean, there's an opportunity and there are a lot of them coming in. But one needed to quickly see the quality, look at scalability and so on. So we had two committees over there. One committee was basically of about 7 to 8 IITs for the domain knowledge. So IIT Kanpur led it along with the other 6 or 7 IITs. And they screened all these MSMEs and startups on the domain part of it, so the oxygen concentrators as well as PSA plants, the technical aspects. And then there was a second committee which was of manufacturing organizations, large manufacturing organizations, screening these startups and MSMEs to see if they can actually scale up. So some system of that nature to be set up together immediately as soon as this oxygen issue came up throughout the nation and there was a huge demand, was also an interesting aspect. And today we are very glad to say that we pumped in about 300 to 500 crores from CSR of some of the public sector units to this entire consortium. And today we have manufacturing setup. So if God forbid we need more oxygen tomorrow, we are quite clear that there are about at least 45 to 50 such organizations which are ready for manufacturing of oxygen concentrators and PSA plants. So that's the second aspect in terms of manufacturing, which was again a big impact. The third one is health infrastructure. This was a time when a couple of innovators from different startups came up and said that there were innovations on affordable and portable hospitals. So we built about 100 hospitals, 52 of them, across 18 states, using about 30 plus corporate CSR funding. And mind you, not a single rupee from the Government of India. We haven't touched a single rupee from Government of India in the Strategic Alliances Division. All the funding has come either from global foundations, Indian foundations, CSR, or from high network income and so on. So that is something that we're very proud of, that we didn't have to seek funds from the government, because the other divisions anyway and other departments anyway fund through government, right? So these are untied, nimble funds which we use, if I may call it that way. So that was another thing that we saw, that those 52 hospitals were built with the partnership with state governments. So the state governments provided 15,000 square feet of land, And you know for a fact that even if you need a 1 square feet from any state government, it takes a year to sign an MOU, etc. But we had 52 such hospitals which were set up in 3 months' time. And so with these deadlines, with 3 innovators, we managed to do this. Those innovators today, I'm glad to say, have got several orders. They've got 500 hospital orders from NHM. They have about 140 hospitals from Government of Meghalaya and so on. So you can well imagine the startup which came up to us saying that we have nothing is today floating in order. So that is the other aspect here, where the entire health infrastructure was also improved during this space, and these would go on for about 30 or 40 years or so. So that's the kind of benefit that one gets. The fourth one would be the startup ecosystem and how we supported them. So about 145 startups were the ones which got support from us. In terms of, most of them just came to us with a proof of concept or with a certificate that this is a certified product or a technology or innovation that they had. So we supported them to engage with these stakeholders. There's an organization called Just Actions. I'm not sure how many of you are aware of them. Just Actions has about 100 foundations under that group. It's an informal group. So we were part of several such informal groups, and every Monday 9:30 to 11:30 in the night I would diligently listen to this group talking about what are the issues and so on, and then we would get the startups to talk to them and present their innovation and so on. So a lot of funding and a lot of mentoring support came from this group as well. So the startup ecosystem also had a lot of benefit out of this entire exercise of the pandemic, and the impact that the pandemic had. Organizations like Modulus Housing, which I talked about, was for hospitals. There was this startup called Black Frog. Black Frog had portable cold storages, and we provided that to Northeast through ST Parekh Foundation funding and so on. And I'm so proud to say that just last week, Dr. Ranjan Pai and I inaugurated their production unit in Manipal. So that's the kind of impact where they today have their own manufacturing units, they're providing it to WHO. So that is the kind of standards the startups have also come up to. They even went to UN Geneva to kind of exhibit their innovations on cold storages. Similarly, many startups who were in diagnostics as well as in other technologies which were supportive of health sector and so on. So quite a few of them today are known names, and many of them have a queue of investors, especially because of this pandemic impact that they made. And then we have exports as well. So we exported a lot, PPEs, masks to the African countries through WHO. So that was the other thing, that we knew that the indigenous technologies and innovations that we have built are of that level that we can also export. So that was the other impact or the other lesson, if I may say, from the pandemic. Similarly, because of the migration, we also had this entire project called the Kisan Mitra initiative, where we looked at housing about the entire national repository of agriculture technologies, 2,000 plus technologies together, and we took it down to the ground, to the farmers, through National Institute of Agriculture Marketing, through NASCOM Foundation, through IM Bangalore, and so on. And today, most of the innovations are known across the nation to industries who are interested in agriculture, those who are, the farmers, the FPOs, and so on. It's not really related to health, but then this was the other impact that we could make during this, entire pandemic. And of course, genome sequencing and global organizations like Rockefeller, Gates Foundation, FIND. We had USAID funding us and so on. So huge, and Azim Premji Foundation as well. So huge amount of funding which was pumped into this entire genome sequencing. Illumina providing us consumables. DHL offered their factories. Tata's as well as Murugappa Group offered their factories and so on. So there was so much of offers, and we ensured that we lapped each of that up, and we also leveraged each of these and provided to the startups which were unknown. One example of grassroots innovators as well as unknown startups is My Labs. Today, I think almost all of us are using the testing kits of My Labs. Those days, they were not incubated by any of the larger incubators or IITs and so on. So somehow they reached out to us and they said we need support. And so we requested NCL Pune and Venture Center, which is based in Pune. And Dr. Premnath is one of the very dynamic CEO over there. We requested him that could this startup be supported. And they had managed to give them space, the HR facilities, all the shared services that is required and mentoring that is required. So that's how today you have My Labs, being supported by this incubator, and all of you have, the benefits of this startup, and so on. So several of these, I can go on and on. There was something like the BSL2 labs, because we also did a whole outreach to rural India through BSL2 labs. Those days we had about 53 BSL2 labs where the COVID testing generally happens. So we realized that we need to have mobile labs, and how do we do it quickly? Because funding is an issue, design of a BSL2 lab is not easy, and then you need to have several clearances and approvals and so on. So Indian Institute of Science and DRDO came up with the designs. Daimler gave their Mercedes chassis. We had Tata Motors helping us with chassis. We had Toyota providing their chassis and so on. And SBI Foundation funded this project. And Gates as well funded some of these projects. So we managed to do quite a few of these BSL2 labs, which were mobile labs, and we provided that to the state governments. Of course, we also tied it up to IIT Madras, IIT Guwahati, Nellore, CMC, as well as Indian Institute of Science, so that the genome sequencing also happens simultaneously. You take the samples and then do the virus studies and so on. So I can go on and on, but because there are too many examples. But to just cut it short, basically what we saw was the entire stakeholder system and the whole process of like-minded and meaningful people coming together to address an issue, and that is something we would like to extrapolate now. And last year we have focused on this extrapolation. We have taken this entire system and the collaborations to different domain areas. So today we do sludge management. There's a center of excellence in IIT Palakkad. We have taken it to IIT Dharwad, where we do clean tech, circular economy in Terry, and several such institutes which have benefited from this. About 23 plus institutes and 145 startups have benefited with this entire pandemic thing, and that's also an after effect of the pandemic is what I think it is. So we have a lot more to do, but I think this was a good start, and we need to be on this bandwagon, and we have to ensure that we make use of this entire platform that we have been provided, like it or not, don't like it. Thank you.
So in general, the COVID-19 pandemic has spurred investment and innovation across India's health system. It's driven advances from integrated service delivery and community engagement to new technology development. And this panel will showcase some of the lessons learned from those efforts and how they can be replicated, scaled, or leveraged to bring sustainable long-term change across health systems and for the population. So very big thanks to all of our panelists today, and we're going to jump into some of the questions that we have for you all. So Dr. Shah is going to kick us off today, and I think the question today, especially for USAID, where you've been investing in projects like RISE, like Nisha, which focus on more integrated approaches to health system strengthening. What does a truly integrated response look like? And what are some of the barriers encountered for delivering innovations that span the whole health system? And what are some of the challenges in bringing together multiple partners for these sort of common goals?
So, good morning, everyone. So, I'll just start off by saying that Dr. Poti mentioned Sanjay was very persuasive and she had to be persuaded to come over here. Actually, I needed no persuasion. After 2 years of attending a first in-person meeting itself was good enough for me. And second is, again, here Devendra is on my right hand side. So he is generally my ground reality check. I get very pumped up with all these big initiatives. He always asks me to come to UP and Bihar and see what's happening on the ground. So with that, thanks for the question. I would say just try to deconstruct what that truly integrated response means. Like each one has got its own interpretation. I wouldn't go into any theoretical framework of what an integrated health system response would look like. But I would just like to say that the truly integrated response, the inspiration came from the government of India itself. If you look at the course of the trajectory of the pandemic, the government of India led the way by even at the early onset having those empowered committees which were there, which were really cross-sectoral, which had all the ministry, different line ministries coming together. So whether it was ramping up surveillance or whether it was responding to the oxygen crisis and so on and so forth. This was then further down replicated at the state level with all those action, the task forces that were created and even right up to the district level. So I think the government of India truly led the way in showing how integrated response to a public health threat emergency such as the COVID pandemic should look like. I think the COVID-19 pandemic again had exposed several fault lines. When the pandemic started, there were fault lines which were exposed, whether it was the ramping of the laboratory testing, the healthcare infrastructure, the capacities of the healthcare workers, and so on and so forth. But then the response to that was an integrated response. If you see all the different initiatives that were launched by the government as a response to the pandemic, we're not really looking at only the response and recovery, but also creating platforms for building resilient health systems in the future. Just to name a few, the top three that come to mind is this fault lines in surveillance, right? We have now the IDSP has been there for decades, but then the integrated health information platform that came to the fore. Second one was, along with that, IGOT, the integrated government online training that was also launched. Along with that, we also had this IPHL, the integrated public health laboratory. That was the network that was again ramped up and it was launched with an effort not only to respond to the pandemic, but even look at future threats. So now coming to what USAID did. So we were well positioned at the start because we had taken some big bets when the National Health Policy was launched into looking at the Health Wellness Center as a platform. So we had significant presence in 12 states, wherein we were helping the government in operationalizing the health and wellness center. So we started off with using that platform, using the community health officers, because true integration happens at the grassroots, at the frontline health worker. A community health officer is the community health officer, which caters to all the different health conditions. So we started off with the Health and Wellness Center platform. But as a response to the pandemic, we again realized that there were gaps in the secondary and tertiary facilities as well. So we launched a network of higher caseload facilities, linked them virtually, to beef up the human resource workforce capacities into critical care management. So that was the RISE network. And it has got a lot of ambitious plans within the next 2 years to ramp up it nationwide and not only look at the public hospitals, but even expand it to look at private hospitals, look at not-for-profit, religious, charitable hospitals that were also at the forefront of the pandemic, and look at even the laboratory networks. So that was the second response that we had, again, which was integrated. And the one more that comes to mind was that in this entire effort, we thought that social entrepreneurs were left out, what Dr. Poti was mentioning. So we launched a financing facility, a unique blended financing facility, the first ever to be launched in the course of the pandemic. So with a 30 million seed investment, we have been able to mobilize around $300 million of philanthropic fund as well as debt funding. So how do we support all those creative, low-cost, frugal innovations that were being launched during the course of the pandemic? So BlackRock, which is a very good example, is being supported through that investment. So through our various myriad projects, we try to look at a whole of system approach, spanning the gamut from right from primary to secondary, tertiary care, and looking at not only the public health system, but even private healthcare providers who are a major source of service provision in the country. Now coming back to the next part of the question, that is the toughest and the trickiest one, is the barriers and challenges. So the barriers, I would say, just change management is always difficult. When the pandemic started, if you have to categorize the groups of organizations and people that we were working with, they fell into three distinct categories. The first category was obviously the first responders, who realized the gravity of the situation. In the middle, there were those fence sitters. Okay, in March 2020, okay, this is just one of those things which will go away after a few months. And now their third category obviously is the skeptics, who are the most resistant to change management and still operating in their own vertical silos. It took us actually 6 months to realize the true gravity of the situation. What we did internally was trying to, because each project operates in its own silos. For the Indians in the audience, they know the challenges of 4S, irrespective of the political philosophy ideology that we have. That Sabka Saath, Sabka Vikas, Sabka Vishwas or Sabka Prayas is easy to say, but very difficult to actually translate it into real life. So this was our starting point. How to get all partners together to have a shared vision. And I would just state it on the record. The way was led and shown by the government. It was not an option. It was imperative. You had to jump onto that bandwagon. So all the partners had to come together. There are real life challenges also that happen. In real life, there is that threat perception that comes from competition and collaboration. There in real life, there are challenges of creating those tools which are for public good, but those are kept aside for business development. So we tried to break those barriers by getting all partners together in a particular thematic area and trying to at least share those experiences. So precious time and effort was not wasted in duplication of effort. One of the biggest challenges that again we found is doesn't exist a landscape of partner organizations working in a particular area and all levels, whether it's national, state or district. So how do you even map out all the appropriate resources? And that is where the collaborations and partnerships came into fore. If the Gates Foundation is doing some phenomenal work or funding some area, then these are the possible areas that we should step away from, or maybe just ensure that we don't duplicate them. So I think there are a lot of real life examples that came to the fore, but barriers and challenges remain. I would just say it is all imperative upon us about how we are using that mask analogy, how you are able to tap into it. The messaging from, again, the government is very clear. In the December Universal Health Coverage Day celebration that was there, in the middle of the pandemic, the announcements were Ayushman Bharat is now about 4 pillars. It's about Health Wellness Center, it's about PMJ, it's about Health Infrastructure Mission, and it is about the digital mission. So within these 4 pillars, there are several initiatives that are launched. All of those are integrated. There are massive financial allocations that are being made, whether it is ECRP or the 15th Finance Commission or ABIM. But there exist challenges in terms of the state's capacity, ability to understand. The guidelines may be rolled out, but the how-to piece is missing. It's not about the technical capacity only, it's about even the managerial capacity. There are significant human resource constraints that exist at the state level. So to Devendra's point, before he makes it, the reality on the ground is definitely very different, but at least the winds have started blowing in the right direction.
Disease outbreaks, and especially COVID-19, are not limited to big cities only, where healthcare is more accessible. What are some of the biggest challenges in ensuring that the response reaches the most remote places? How do we leverage or repurpose existing systems and networks for disease outbreak response, but still ensure patient access to regular routine services? And how has some of the recent innovations around things like bidirectional screening helped us improve health services?
I think as an Indian, I always feel that, so whenever there is a crisis, we can deal with it. Our ability to deal with the crisis is just unprecedented. I think we will, so it is like my student days. So there is a 1 year for preparation for exam. For 11 months, we will be doing all kinds of things. But those last 1 month, we will make sure that we will get through. So, and I think that confidence that I will get through in the last minute, I think it pervasive, it encompasses everybody's mind space. That gives confidence, but also that puts a very interesting weaknesses also on the way forward. I think as a Gates Foundation, when we work in the health systems, Uttar Pradesh and Bihar with the population of around 340 million population. These are our two priority states, and we focus on these priority states. It's a privilege for us to work with the respective state governments through the formal understanding with them, working on the different aspects of the health system. So when the pandemic struck, many people and many well-wishers and many thought partners were asking, okay, now this is the time the UP and Bihar health systems will crumble. It was everybody's expected guess that these states, given the infrastructure and given the other issues in the health system, they will generally fail. I think when I look back today, while the crisis is still, it is not, we are in the middle of it, but I think it is a fair statement that both the governments laid the way in such a way that we can proudly say that Uttar Pradesh and Bihar, despite the health system challenges, whether we are talking about health infrastructure, whether you are talking about increase in the diagnostic capacity, whether you are talking about overall surveillance approach, whether you are talking about the treatment facilities, whether you are talking about other elements of so that social challenges are addressed. I think from the COVID lens, I think the health system in both the states, it is thanks to the leadership and thanks to the overall the workforce on the ground, they have done, I think, definitely one of the stellar job in the COVID management. I think coming back to the question about, there is often a question and there is a hypothesis, there is an involved hypothesis in our mind that the cities are doing better and the rural areas are inaccessible or there are challenges. I think I will challenge this hypothesis itself. It is a continuum. There is nothing like there is one big city and there is an absolute remote area. There are big cities, very municipal, small urban areas, rural areas, and very remote far. So it's a spectrum that is available. Generally, the accessibility point of view, either the big cities like Mumbai, Delhi, Chennai, and many other places, which do have the municipal corporations and the health infrastructure and the large number of the private setup, they naturally do have a distinct advantage of accessibility. Rural area, our whole health system generally is designed in a way, in a rural-centric way. So by and large, there is an infrastructure available to that. What comes in between is the small urban towns, which neither falls here nor there, and which faces a unique challenge as far as accessibility is concerned. But I think before we go to the urban and the rural, and I work for my significant part of my time on polio surveillance and disease surveillance, around 11 years in polio surveillance. I think the general question we should all ask is, I think in the war-like situation, in a crisis-like situation, we'll all come together, create a beautiful model, but there is a famous line which says that the love which is created during the wartime is not necessary that it will continue post-war situation. So everything that comes together in a crisis situation, is it streamlined in a way that becomes a part of the routine health system? Now, for COVID, we have done a fantastic job. But as a system, are we designed in a way that we can predict the outbreak in a reasonable way, in a timely way? Whether different surveillance systems are integrated in such a way? There can be examples of polio, there can be examples of TB, there can be isolated examples of measles, mumps, rubella, there can be few more. But can we say that in the sphere of infectious disease, I'm forgetting the non-communicable part, are we really predicting the outbreaks in a timely way? So what is the, and I think we know the answer, but I think that's the, to me, that's the central part of it. And one of the challenge which I see around it is either we need everything. I think we need data from everywhere, from every nook and corner of the country. Either we will do everything or we will not. I think, can we develop certain differential ways of approaching the disease surveillance? Do we need in the time of enhanced genetic sequencing and genomic surveillance, do we need to know numbers for every disease every time? For certain diseases, it is okay to know only trends. For certain diseases, it is okay to know only genotypes. For certain things, we may need the absolute numbers. So how can we create a system in such a way that we are very clear, out of these 20 or 30 diseases, for 4 or 5, we are okay with the trends, and we are okay with the geographical focal areas. For certain areas, we will need some stronger and absolute numbers. So long as we use our mind, we start thinking in a differential way for the disease surveillance, many of the problems will be easy to and manageable to solve. Coming back to the, still there will be, of course, I think that it will be no wonder that rural areas will be at loss or in disadvantaged situation than the urban area. And I think I see as only two challenges there. One is the point of care diagnostic. Now, and point of care diagnostic, not in isolated way, but integrated with the current health systems. So one is the point of care diagnostic and its linkages with the labs, respective labs. I think that is one part. And that is, in general, I will say that is the first bottleneck in any such thing. Second is absence of integrated approach to all this. And integration is a common theme which we will talk about this surveillance. I will give you the example in Uttar Pradesh. For example, we were not, for anybody's imagination, they came out with the unitized, we were a very proud partner, played a small role in that is, the government came out with the unitized digital platform for the COVID surveillance. For the first time, it was unitized. It was linking with the patients, the government labs, the private labs, simultaneously. Generally, either all the permutation and combination that moves around in such platforms. But I think everybody in that space agrees that unitized digital platform, but that was for one time, and how now the question is, how do we capitalize such platforms to make it more integrated for wider network of the diseases? I think I will come to the second part of your question. So what are the different, how can we reshape the health system and something like that, or what are the opportunities there? I think first is, there is a difference between a clinical surveillance and a public health surveillance. I think many times we approach both the clinical surveillance and the public health surveillance simultaneously. Can we differentiate it? Two, can many of these diagnostic and surveillance technologies will be adopted according to the health service delivery platforms? What are the health service delivery platforms? There is a facility platform and there is an outreach platform. Can we link with that? And the last point is, more and more, Amit talked about health and wellness centers. This offers a great opportunity for many of these platforms to be explored for the NCDs and the communicable disease. I will stop. Thank you.
around what impact did COVID-19 pandemic have on your laboratory network? How were you able to meet demand and approach scale up? How were services integrated into the public health response? And what lessons do you see for other diseases like tuberculosis and other major global health diseases?
Thank you, Emma. As has been rightly said, that it is not possible to say no to Sanjay and Sarabjit. My privilege of being up here, I think for the first time for an in-person meeting after more than 2 years. Let us realize one thing, that we do not regret, that we did not have the foresight to know what was there in the hindsight. Time for gap analysis. I've taken off my mask because I want to speak to you from the heart. The reason is that I was one of those who was actually in the middle of things, when the bullets were flying right and left, when problems were many, solutions were few, and we had to take quick decisions, immediate decisions, because time was of essence. Emma, I would request that you ask me questions one by one. I'll start answering from question number 1, and then I'll proceed, because I may tend to overlook certain important facts. Let me answer the first question. It was in March that we realized that something called COVID virus outbreak was taking place. Till that time, first patient had been identified on 30th January, if I'm not mistaken, in 2020. I was on a TV show with Dr. Vinod Paul, and we said, we have touched 100 patients. I said, my God, 100 patients. What will that happen? Before we knew, we were in the middle of it. The government told us that private sector laboratories, those who want to volunteer, those who have got enabled accreditation for H1N1 testing, you are allowed to do COVID testing. I think mine was one of the few laboratories, I can say, among the first 5 who started doing this. We did not have a clue about anything what we were supposed to be doing. There was so much of a knee-jerk reaction. A lab which was running routine diagnostics was suddenly converted into a COVID lab, where maximum patients were coming with COVID patients. Every day there was no problem. There were no kits. We would negotiate and said that there were only imported kits which were there. What am I supposed to do about it? There was price capping. I could not charge more than a certain amount. There were no PPEs, there were no protective gear, there were no masks. If they were there, they were so expensive that they were absolutely unaffordable. As soon as we would solve one problem, and they would come. Some or the other we managed, as we had molecular labs, we managed to start testing by getting kits from abroad. I remember it was from Seegene and Altona and all those foreign companies and Thermo Fisher kits which we started using. The government told us, no, you only have to use the ICMR approved kits. You cannot start using your own primers and probes and start testing. That was another challenge for us. The kits were just absolutely in short supply. I remember talking to my colleagues from different labs, actually at 4:35 in the morning, begging them for kits. The kits had to be validated. The kits had to be standardized. The quality had to be maintained. We just simply could not have started giving reports without gaining the necessary confidence. Then came the challenge of manpower. From where to get trained manpower? I had in my lab a limited number of molecular biologists, but were they sufficient enough to sustain and to maintain and give reports to the large number of patients that we were getting? We had to get more manpower. More equipment was so expensive. We had to take it out of our own pocket. There was no government subsidy, etc., which was being provided to us. And above all, the reports had to be given in a certain timeline. Dear friends, how many of us would like to go to somebody's house, tell them to open their mouth and take a swab from there from a suspected patient of COVID? There were very few people who were willing to do that. Staff, the front-end staff, just simply refused. So what did I do? At least I can only go by experience. I said, I will lead from the front. 7 o'clock in the morning, we used to hold a meeting every day, where I used to give them a pep talk and tell them, look, there's a war going on. In 1971 war, we knew who the enemy was. He's the enemy which we do not know anything about. The first COVID sample I took was myself. I used to call the patients, tell them to open their mouth, put on the protective gear and take the sample. And I could say that if I can do it at the age of 60 plus, so can you come do it. Hold my hands and we'll do this together and we will win this battle. But every day there was a new problem. The kids would dry up, the protective gear would dry up, and the new things like borders would close down. There was no transport allowed from Haryana to Delhi. I always wondered, are we not living in one country? Most of my staff was staying in Haryana. It was impossible for them to travel from there to Delhi. How could I solve this problem? So again, it came to where the buck stops. That's me. And my young colleague sitting out here, who is accompanying me today, we were inside the molecular lab from sample collection to doing the testing all on our own cells, because there was no option. Then again, report the cases. Every second day, the sample requisition form would change. So that was the challenge, to how to put it on the net, how to tell the patient how to fill it up. I was told a prescription is mandatory for every test which is being done. Patient would actually catch us on the throat and say, why do you require a prescription? To convince them that these are government orders and you have to comply for them was again a challenge. So every day we fought it out. Yes, rightly said, it wasn't a battle, it was a war of a lifetime. Mind you, it has not ended, it's still going on. And the worst came when the front-end workers started falling sick. When the front-end workers were falling sick, the family would say that with the stigma attached to it, that don't go home, don't come home, stay somewhere else. I had to create a hostel facility for them, to have food cooked at home and to be served to them, and then to have them motivated, have the clothes ironed. All of sitting out here, I'm speaking from the heart and telling you what the core fact and reality was. So running a lab at that time where our reagents of the routine test totally expired, because there were no patients coming from them, we had to do something to make it sustainable. And the government orders, increase capacity. How do we increase capacity? Increasing capacity requires manpower, equipment, finance, and space. I love my country. I love my countrymen. I have earned well over the last 60 years. Vinita sitting out here, who saw me when I was 30 years old, and it started from not even 200 square feet of space. I said, yes, this is the time for me to give back to the society. But then what to do about manpower? From where could I get it? It was not possible. The duties were high. The equipment getting was an impossibility. There was a line. I had to use actually like our pull, as you can call it, to get more and more extractors and get more and more amplification systems and machines. But then, just now, I was smiling when Dr. Sapnapoti was saying that it's very difficult to get space in the public sector. You mean to say getting space in the private sector is easy? All of you, I'm quite sure, have your own houses. How much does it cost to buy a building or a place or a space? It is so very expensive. We could not afford it. The staff was working 24 hours a day. The food was being served to them there only. Everything was there. But I can say proudly that we survived. Now is the time to do the gap analysis of what happened and what should be done as time goes by. The problems have been a lot. The solutions have been found. But there was one major credit I give to the government, that was the Atmanirbharta. Atmanirbharta was actually a game changer, so that we were no more dependent upon the kits, regions, etc. coming from abroad. The kits would be manufactured out here, the costs were comparatively brought down, they became more affordable, but not the last the least. It was quite interesting. A large number of court cases were being filed against the medical profession that bring down the cost. Why are you charging 1,200? Why are you charging 300? A person who's going to collect the sample from somebody's house, we have to give him some incentive. Why would he do that? It was not only the cost of the reagents which were being calculated by different honorable courts, they did not take into account all the other infrastructure which we had to provide. So this was the initial part of the struggle. Next question, Emma, please.
So I think that was a really fantastic setup, reflecting on some of those very hard lessons learned. I guess my next question is, what are some of those lessons that you would take through to other diseases now, tuberculosis and other diseases? Those are some pretty hard lessons that were learned from that experience. What does that mean when you look forward for other key diseases?
I'm so glad you have asked me this question, because according to me, there are other diseases which deserve or which need actual attention, rather more attention than what COVID has done. COVID has not ended, mind you. That's why so many of us are here still in mass form. I do not know what the next variant is going to be, whether next time I'll be allowed to come here with the mask off or not, whether I'll have the guts to do that. The example is, I can say, that we scaled up by starting with opening drive-through centers. And our drive-through centers, they have been published in various journals with very high impact value. Number two, we put in machines like gene experts. And that's where the answer to this question comes. First, we had 2 gene expert machines. We invested more, which costed a huge amount. Those same machines can be used for fighting other diseases like tuberculosis. For me, tuberculosis has not been just one of the diseases. For me, it has always been a passion. Here, I need to reiterate the fact that many years back, that we started an organization by the name of IPACT. I remember this name very well because I still remain a part of it, and I quote it everywhere. And Saratjeet was a part of it. He's here. I can see Harkesh, who's out here. And all these colleagues of mine, along with a few of us, started this particular project. That IPACT model can be used to combat, fight, and diagnose and treat other diseases also. IPACT, for those who do not know, was initiated for providing affordable quality testing for tuberculosis. There, under the guidance and leadership of Madhukar Pai, Sarabjit, Harkesh, Dr. Lal, and all, we all came together and we brought a large number of labs under that umbrella, had large number of conversation, discussion, dialogues with various manufacturers to bring down the cost so that we could make it affordable. And we succeeded to a large extent. We could bring in many hundred of the labs under the umbrella. The same model can be used for fighting other diseases also. But again, while today I'm sitting here with you, I'm a little disappointed that IPACT still remains a fantastic model. Day before yesterday, I got a mail from one of the manufacturers. I have no inhibition in saying that because they're in public domain, from Cepheid, that for the new machine for HDR and MDR tuberculosis, they've increased the rates. My friends, do you realize a few thousands for diagnosing tuberculosis for the population of a country who can ill afford it? I think we need to struggle more. I wanted to buy a midget, but I was told that midget no more comes in my IPACT. I don't know why. I think that last we heard was that was very much a part of IPACT. So we have to see to it through advocacy that the diagnostic companies bring their costs down. The duties are decreased. We can make it affordable. My friend sitting out here can vouch for it, that we decided on a certain price and not even 1 rupee was charged more than what the decided price was. It was quite affordable. For tuberculosis, I'm sorry, maybe I'm overshooting my time, but I'm speaking from the heart. If I think one of my colleagues mentioned, again, that the private sector has not done much. Private sector does not have the space to do it. I may be stirring a hornet's nest by asking you that most of us want to enroll for the National Tuberculosis Elimination Program, which is a must for doing so much of work and projects. But they want biosafety level 3. To set up a biosafety level 3, those of you who know about it requires so much of space. From where does the private sector get that much of space? I think about biosafety level 2 or 2 plus should be adequate enough. So all these informed decisions must be taken to see that we take this forward to the private sector's involvement in other diseases besides COVID also.
And I think there's some valuable lessons there, the start of a gap analysis, but I think you're right, there needs to be more of an examination of what some of the broader lessons are learned for effective coordination with the private sector. I'm now going to switch, and I think there were some interesting lessons there from the hot seat right from 2020 of the acute COVID response. So I'm going to turn to Dr. Runa on the broader question on health security, which I think rarely gets tested like it was tested in April, May, June 2020. What does health security mean for India, considering its size and geography? With gaps in our health security that have been exposed by the pandemic, what are the same gaps if you look at other diseases like tuberculosis or hepatitis? And what innovation is needed in the sector to change the dynamics?
Thank you, and thank you to Dr. Emma and Dr. Sanjay for the opportunity to represent CDC on this panel, and for your excellent questions. I think certainly health security has come to the forefront in the last 2 years. I think we can safely say that many people who did not know what health security was or pandemic preparedness are now fully versed in those terms. So I think when we're speaking of India, given India's size, its geography, and its disease burden, India is a pivotal player in global disease burden control as well as elimination. The 4 core areas in which CDC supports those efforts in India are in laboratory strengthening, in building emergency response capacity, in improving disease surveillance, and in workforce development. So those are really the pillars that enable a nation to detect and respond to public health threats. I think given the number of points of entry, both in terms of seaports, airports, and border crossings, there is significant threat to India in terms of importing disease and spreading disease. So critical that these 4 areas are built up. So in terms of health security, there is an important role for India to play, and India is stepping to the plate to play that role. I think some of the innovations that Dr. Amit mentioned in terms of the integrated public health laboratories, that's been a significant step forward in improving our ability to train personnel that are able to detect diseases and respond to them, as well as to build diagnostic capacity so that we actually know what the true picture is of disease, both at the district and the sub-district, and then state and national level. In terms of gaps that have been unmasked by COVID, I don't know that those gaps are necessarily so different for COVID than they were for TB or hepatitis or HIV. I think in emergency management, we talk about 3 areas where attention needs to be focused: the staff, the systems, and the stuff. And I think that is true regardless of what disease area you're speaking of, or even what aspect of health security or disease threat management that you're speaking of. So there's a need to make sure that you have adequately trained personnel. There's a need to make sure that the systems are in place to detect and respond to the threats. And there's a need to make sure that there are adequate resources in place to actually address the threats that emerge. So some of the areas specific to laboratory where we see that are the need for safe labs, and I think the areas of opportunity that have arisen are to address quality management systems in laboratory, including biosafety certification and risk assessment. Then in terms of well-trained personnel, I think that there have been multiple attempts at mentorship and successful attempts at mentorship. So I think that's a huge component of ensuring that there are adequately trained personnel, and that is a sustainable effort, is making sure that those mentorship systems are in place to build and cascade those trainings. In terms of effective and efficient testing, this is also an important area in building up laboratory capacity. And one of the areas that we've been supporting the Integrated Public Health Laboratory Network is in developing the capacity for multi-pathogen diagnostic capability. So that will really be able to move our lab systems forward in terms of the efficiency with which they're able to detect and respond to public health threats. And then in timely information sharing for action. And I think this is where we get into, as some of the previous panelists have spoken, that having those laboratories with the capacity to diagnose multiple pathogens is important, but being able to provide those data for further action is equally important. So here we get into integration of laboratory data in something like a laboratory management information system that can be integrated with the Integrated Health Information Platform, IHIP. There are such opportunities here to really bring the epidemiologic and the laboratory data together in a way that the nation, the state, the district, and the sub-district can really have a strong idea of what their disease threats are and mobilize their resources to respond to them. And I think one of the other areas that the government has committed itself to that is really commendable is in building a national and subnational system of public health emergency operations centers that will really have that capacity to intake that information, both from the epidemiologic side and the laboratory side, and then contain a cadre of well-trained epidemiologic professionals and outbreak response professionals who are able to take those data and then translate them into containment and mitigation measures on the ground. So I think that those, and I think one of the areas that was also brought up by previous panelists was in this need to determine what level of biosafety is necessary in order to address the most dangerous or threatening pathogens that are out there. So I think this is another area of opportunity, is to really have a coordinated national discussion on biorisk and biosafety and what the current capabilities are and how to build up our capabilities to be able to detect and address priority pathogens as they may be defined at a national level and even at a subnational level, because those high-risk pathogens may be different for different areas of the country based on what the current threats are in those areas. So I think at the sub-district level, being able to build that capacity through block public health units and through IDSP to really define priority pathogens and then make sure that the appropriately leveled diagnostic centers are there to detect those threats and then transmit that information to an outbreak response center who have the trained personnel to respond to those threats. This is really the vision, and I think that the government of India has made incredible strides through the pandemic to achieve that vision through IPHL, through national and subnational EOCs, and through really talking about level of biorisk capability and what needs to be done to move those capabilities forward.
Wonderful. I think that was excellent reflections, especially when we talked through the extent of the challenges that we see. How do we marry together some of those lessons learned to actually change the dynamics, especially for such a critical country, as you said, like India? My last question is to Dr. Rami. We've spoken a lot at a whole systems level. We've heard from Dr. Navin about the experience of interacting directly with communities to encourage them to test and to be able to take their own samples. So I think communities are critical for access to healthcare, and I wondered if you could reflect a little on how their role has changed during COVID-19. What are some of the learnings from reach amongst TB communities that you think could be adapted as a result of the COVID-19 pandemic? and what is the optimal role for communities within the health system so that they stay connected to broader public health efforts and to concepts like global health security that are otherwise sometimes a little bit removed.
Thank you, Emma, and thank you to FINE for giving me this opportunity. And I'm happy I'm going last because I think this esteemed group understands that no matter how much funding we have, no matter how robust our diagnostic tools are, no matter how strong the private sector is or how much the health system is strengthened, without communities' participation, we cannot move things. Be it wearing a mask, be it taking a vaccine, or be it coming to health facilities to actually undergo the testing. So I think that is very, very critical, which is this community participation. And especially engaging affected communities is very important in translating the grand ideas that all of us have to translate it into actionable things at the local level, because many times what we see is that everything is on paper, right? It's either in a framework or in a guideline or in some documents, but where the challenge is in operationalizing it. And I mean, in a country as big as India, which where even two states are not similar to each other, it's very important to find these local solutions to take and address this last mile gap in healthcare delivery. And that's where I think communities and communities' ownership is very, very important and critical. And what we have learned by working with the affected communities, especially the TB affected communities, is that the lived experience of the TB survivors could actually help in providing advice to the program, the national program itself. We just want to share some examples of what we did with the TB affected communities, and then I just move on to the COVID pandemic and their response in the COVID pandemic. I think we started in 2016 to broaden this response to TB at the community level through the Call to Action project supported by the USAID. We started engaging with a group of TB survivors and trained them to become TB champions. And what we learned along the way is that these TB champions are very, very committed to give back to the program, to give back to their communities, and to work for TB care and prevention activities. They have shown that they are very committed to the cause not only of TB but also of public health. We also facilitated the formation of networks, which are groups of TB survivors coming together as TB champions. And these networks provided a collective voice for all the affected communities, which could go even to the decision makers. We started the program, I mean, it was a model, but today it's evolved in ways and means beyond our imagination. And very happy to say that today the TB champions are designing how they would like to participate, not just in TB care and prevention, but also in TB response. So it's become truly a program which is being owned by the communities, it's for the communities, and it's of the communities. Today we are finding that the TB champions are doing different roles. So there are some who actually provide service care delivery. There are some TB champions who advocate for better quality of care, better quality of services. So they serve as the eyes and ears of the health system in the communities. So if there are gaps in the healthcare delivery, they are able to take it to the health program and say that these are the gaps, how can we actually help address them. Today the TB champions are not just pointing fingers and saying, look, this is not happening or that is not happening. They're also part of the solutions. We are working with the program to find solutions for the affected communities. And we have very many examples of the work that we've done across the country. For example, recently in Bihar, we had TB champions, especially during the COVID times, where they were acting as peer counselors, helping address the gap in the healthcare system in terms of providing counseling to people with TB. and providing telephonic follow-up support and finding gaps such as who are the people not taking drugs, who are not getting the follow-up testing, and linking them up to the program so that the access to diagnosis and treatment is uninterrupted. We had the women TB leaders in the state of Tamil Nadu, who actually, I mean, all of you know that during COVID times, laboratory technicians were pulled into COVID, right? And routine laboratory services were disrupted. So we had women TB leaders trained to actually fix smears, even run TrueNAT machines, and they helped in addressing that critical gap. And this is where investing and nurturing in communities is very critical. I mean, we can't wait for somebody to take some action somewhere and then systems to flow down from national to state to district. I think the communities just took ownership and said, okay, here the lab technician had to go for a COVID-related duty, so let me pitch in. No, you teach me how to fix a smear and I will do it. So that has been the power of working and engaging the affected communities. We have examples where in Chhattisgarh, recognizing that both TB, COVID are airborne respiratory infections, how this chulas actually play a role in exacerbating COPDs and respiratory diseases. So we had them helping in establishing the smokeless chulas in Chhattisgarh. We had examples of from place, I mean, in like Odisha, where when people with TB got affected both by TB and COVID, many of them actually helped the people to get access to the social support and welfare schemes available. Even there were some of them who actually helped in getting legal support to the people both with TB and COVID. So I think the affected communities played a tremendous role in providing these local solutions, which it would have been very difficult either for the program or like program managers like us who are implementing the program to actually do it. They were on the ground helping to provide these services, and I think that has been it was a truly humbling experience for us to see how it evolved, because I think here many of you will agree with me that here many of us had the luxury of working from home. It was the TB champions, it was the women TB leaders, it was the TB numbers who were actually at the ground providing care and support to people not only affected by TB but also with COVID. Specifically with response to TB, COVID, and during the pandemic, we had these TB champions facilitating the bidirectional screening, actually transporting sputum samples and helping a person to get diagnosed with either COVID or TB or both. So I think there are, the work in the last 2 years has really opened our eyes to the ways in which affected communities can participate in a public health program. And what do we need to do for that? We need to invest in them. We need to identify them, we need to train them, because the commitment is there, that passion is there. Every single TB champion, when they narrate their journey, for the very first time when they come and speak in any get-together, they are people who are not even able to narrate their experience without shedding tears. And today, they stand here in various platforms, in national, international, district, state platforms, with speaking with even the health ministers, with the bureaucrats, with the secretaries, advocating for the rights of other people with TB, sharing the gaps that they are seeing at the ground level. And that is really a very, very transformative response which the TB survivors have gone through. And as I mentioned, for the community participation, it's very critical to invest in communities. It's important to invest in their training. And I think, in fact, the number of trainings that we offer to them are very many. So we have a basic survivors training, we have accountability training, we have training on quality of care, quality of services. Today we have TB champions looking at data to say that, oh, okay, so TB, COVID is a problem, and we need to focus on these areas. So they can understand data, So, I mean, it's literally a bachelor's degree, I feel, that these TB survivors go through, and they have really transformed into true TB champions. And what I'd like to sort of end with is that what we have seen along the way, now we have scaled this up through the Global Fund initiative, is it's been a win-win in two ways. One is the communities have benefited. The people whom we need to reach out to, the people with TB, people with symptoms of TB, people with COVID have been reached out to. The health system, they have found an ally in the TB champions, because today they work hand in hand with the TB champions. And finally, for a TB champion itself, it's been truly an empowering experience, because for many of them, that was the first time they stepped out of their communities, stepped out of their home. The first time they even actually speak to a group of people. Today they're very comfortable. Especially during the pandemic, when we had to meet with them, speak to them, train them, use virtual platforms. So today they are as a TB champion, even in a rural district, is as comfortable logging into Zoom and Google Meet and any platforms, and taking virtual calls as we are. I think that has been a truly humbling experience for us, this whole empowerment. And to be very honest, who would have thought TB could actually provide a platform for empowering such a huge group of people? And today, I think they are evolving, because they were the first people to put up their hands during TB COVID, saying, look, how can we help people with COVID also? So they came up with a lot of solutions. They mobilized additional nutrition support for people who had both COVID and TB. And they were the first people putting up their hands. How can we encourage communities to increase vaccination? So please give us information. Please give us materials which we can go into our communities and encourage other people to undergo vaccination. So that was the kind of response that these affected communities had. So I think today, post-COVID, and while I wouldn't say post-COVID, we are in the midst of it, of course, but I think these affected communities have really evolved into not just TB champions, but true public health champions, and they can be tapped into for any public health challenges. And we have go-to people in the community and who are actually recognized as leaders within their communities to take forward any public health program. Thank you.
I think the idea of those very localized solutions that you talked about, that experience really on the coalface, shared with Dr. Navan, I think that was a really valuable perspective. As you said, many of us had the luxury of working from home during this pandemic. That wasn't a luxury for all of us, for those who actually had to work at the coalface of making things happen. So just, I think, in short summary, and we won't have time for questions from the audience, but we are going to go into a tea break, and so hopefully our panelists will be around for that tea break, so you'll have a chance to ask those questions one-on-one. I'm stealing a line from Dr. Devendra, who said, our ability to deal with a crisis has really been unprecedented and tested with this pandemic. I think we've heard from Dr. Navan about the realities of what it was like early in that pandemic, about getting Dr. Runa's 3 S's, the staff, the systems, and the stuff, to be together with the right policies and the right enabling factors at the right time. And all of those broke down at different points and at different times, and sometimes, by the sound of it, all on the same day at 4 o'clock in the morning, which is humbling to hear about. I think we've reflected a little bit on some of the lessons that have been learned from that pandemic today. I think the first lesson we've heard about is that role about integrated care and systems-level care. We've heard that across a number of panelists. We've heard about the role of technologies in this, but also beyond just the technologies. We've heard a lot about staff, about healthcare workers and laboratory workers and their roles in making sure that this happened. Make sure that we understand the full requirements and the full costs for diagnostics delivery, not just of the reagents, but making sure that we can go out, take the samples, get the data processed, all of those aspects that come with diagnostic testing, whereas sometimes we do tend to focus very heavily on the technologies and the reagents in general. We've heard about those linkages through to global health security and to outbreaks, and that connection through to the really local service delivery, what it means to really localize this within an actual village, within an actual community, to be able to make that happen. So I'd like to give a huge round of thanks to all of our panelists today for the start of this conversation, which I know will continue both throughout the day for us, but also be a reflection for all of us over the months and years to come on the lessons from COVID.
We wanted to kick off the second half of the meeting today with an address from our Chief Executive Officer, Dr. Bill Rodriguez. Dr. Bill Rodriguez joined FIND as the Chief Executive Officer on 1st of July 2021. A physician and entrepreneur, he has extensive experience across both the private and the public sectors, founding his own diagnostics company, Daktari Diagnostics. Bill is a highly respected figure in the global health community, serving as an advisor to the WHO, the BNPF, national governments on global HIV, TB, Ebola and COVID-19 programs, as well as numerous established and startups for not-for-profit social enterprises focused on global health. Bill is a graduate of the Brown University and the Yale University School of Medicine, and trained in infectious disease medicine at the Brigham and Women's Hospital in Boston, where he served as the chief medical resident. Bill was very keen to come down for this meeting in person, but unfortunately due to certain other pressing exigencies, he was unable, but has promised that he will be back in India shortly, and will of course have an opportunity for another face-to-face with him. Over to you, Bill.
Hello, good morning, or I guess good afternoon now, and belated welcome. I know we've already had some productive sessions this morning. As Sanjay said, I'm sorry, travel keeps getting disrupted on my part, and I haven't been able to join you there in person, but I will be there again soon. My name is Bill Rodriguez. I'm the CEO of FIND, and it's a privilege for me and for FIND to host so many distinguished guests and speakers today on this topic. Just to reflect for a minute on the pandemic, I think as we all know, the pandemic has really taken an enormous toll so far on our families and our communities, on our loved ones, and on our social and economic activity. COVID will have long-lasting impacts across the world, and ones that future historians will discuss for many years, the way they talk about past wars and past plagues. But I think perhaps the most immediate impact will come from the realization that although this world has grown increasingly connected in the past 75 years, with global supply chains that stretch from Chennai in China to Nairobi in New York, when it comes to protecting the public health, nation states have realized that they can no longer rely on others to come to their aid in a crisis. So this concept of self-reliance on protecting public health is one every nation is discussing right now. I know that even before the atmanirbharta mission, India already established a strong track record of self-sufficiency in healthcare. India has been pharmacy to the world, manufactures and exports more than 60% of the world's vaccines, as you all know well. And there was an incredibly fast ramp up in local production for PPE and for vaccines for COVID-19 at the start of the pandemic. Yet, even as the pandemic unfolded, even India found itself at the mercy of the global supply chain for key supplies like oxygen canisters and critical diagnostic test kits. So sitting where we sit at FIND and looking at India's vast capabilities and the strength of its technology enterprise and the skills, we saw tremendous progress in diagnostic self-sufficiency over the last 2 years. But it's clear there's still work to do. And that's why this meeting and this discussion is a critical one for FIND as well as for India. We have to catch up to the achievements on drugs and on vaccines and on other key health commodities with diagnostics and diagnostics self-sufficiency in India, and for India to be a model for the rest of the world on what it means to establish critical commodities and to use those tests broadly in the Indian healthcare system. We see India as a critical role model for the region and even for the rest of the world. So we have to catch up. Not having tests and the tests that we need and not using those tests means that the treatments that people have worked so hard to develop will sit in boxes on shelves unused instead of saving lives. And not having the tests that we need will leave us blind to the emergence of new variants of COVID-19, and it means that national efforts to end TB and hepatitis and to address the non-communicable diseases will be led by experience and instinct rather than data. So not testing is ultimately like covering our eyes and being unprepared and exposed to COVID and other diseases rather than being prepared and responsive. So since the development of India's economy has had technology at its heart, we've already seen how that's led to great progress in diagnostics. And diagnostics innovation that's been accelerated by this pandemic has spanned not only the testing technologies, but manufacturing innovation, policy development, operations research, epidemiologic modeling, digital tools, data management tools, more robust supply chains, and all of those are critical for testing to be integrated into routine healthcare. So just to talk about one example that many of you know well, MolBio's TrueNat diagnostic platform has been part of the backbone of the PCR testing response to COVID. And we were very pleased to work with the India Health Fund to support testing efforts by the Municipal Corporation of Greater Mumbai for both COVID-19 and TB, and to deploy TrueNat machines in hospitals in Mumbai, which is a step forward in the so-called bi-directional screening. And I want to highlight how transformative this simple effort can be. So what we refer to today as bi-directional screening, meaning looking for tuberculosis in patients suspected of having COVID, looking for COVID in patients suspected of having TB, it seems like a small step, but it's an essential step forward in a major transformation in how testing will be used in healthcare in the future. In the future, with innovations coming from companies like MolBio, we'll stop asking the question, does this patient have TB? Or does this patient have COVID? And rather we'll ask, why is this patient sick? And that simple switch in brain and the test that we use at primary health level will be able to answer that question, what's wrong with this patient? Rather than leave us unsatisfied when a test for TB or a test for COVID comes back negative. We want to test for all conditions and all diseases at the primary health level in a single system rather than focus on one disease. And it's an approach to care that starts with patients and not with diseases. So for that reason, getting tests closer to patients is a very high priority, not just for FIND, but for anyone who's delivering healthcare in any setting. Globally, we've seen the pandemic accelerate technology development across the world, and we now track 56 new near-patient multiplex molecular diagnostic tests that have been launched. So these are tests that can detect multiple diseases from a single sample. And 15 of those systems are truly usable at primary health level. On the testing capacity side, that's the technology side. On the testing capacity side, India's laboratory networks have shown how you can scale up at breathtaking speed when you need to. We've seen that in the pandemic. As one example, the Translational Health Science and Technology Institute, THSTI, in Faridabad, was able to reduce sample processing time from 8 hours for 100 samples to 2 hours for 200 samples. And if you haven't seen that video, that explains and shows how they did it. It's worth watching at some point during the course of today. We also know that laboratory services and testing technologies aren't the only essential components to patient diagnosis. Our partnership with CSAR-IGIB, the Institute of Genomics and Integrated Biology, helps set up microlabs that boost genomic sequencing capacity, and that has enabled surveillance of diseases at the district level. And India's strength in genomic sequencing is something that we think can expand globally, both as a model and as an export of critical components. And we're also very keen to understand what this could mean, not just for COVID and pandemics, but for tuberculosis and monitoring and testing of drug resistance for TB. So I've just highlighted a few of the partnerships that we've been involved in. I could highlight many other partnerships, many with organizations represented today in the room. I'll just note that FIND first opened our office in Delhi 15 years ago. And just understanding the energy behind this meeting and in the room today, it's inspiring for me to consider what's next on India's journey to self-sufficiency, to atmanirbharta in healthcare, And I look forward, and all of FIND looks forward to working with everyone to see what we can achieve together in the next 15 years. So thank you very much for your attention. I'm sorry I couldn't be there today in person. I look forward to seeing many of you later this year, and good luck with the rest of today's meeting. Thank you.
Thank you, Bill, for your thoughts. I think particularly on how India can be a role model, not just for the region, but for the world. I think in some ways it already is. And also particularly the focus on increasing access to healthcare at the primary healthcare level, investments in point-of-care technologies, specifically the multiplex, and keeping the patient in the center rather than thinking of it as TB or COVID, essentially diagnosing what the patient has come in for. So I think that in itself will be a huge change in the mindset and a sort of a paradigm shift as we move into a post-pandemic era. So Bill, I know you're busy, but you're most welcome to stay on. We have a very interesting and a power-packed panel which is going to focus on healthcare innovations in India and how some of the partners are actually contributing to that journey. So with this, I'll now invite our moderator for the next panel, which is riding the atmanirbharta momentum to transforming India's healthcare delivery, Mr. Chapal Mehra. Chapal is a public health specialist, writer and commentator. He works on issues of health, particularly infectious diseases, development, gender and human rights. He's worked extensively with communities, the media, and then civil society to advocate on key issues in health and development. Chapal.
Today morning when I was getting ready for this session, over the last 2 years, I must have moderated close to 40, 45 panels, and all of them are on Zoom. So I was saying to someone, and to one of my panelists, and they started saying I should tell you all this story, so I'm going to tell it to you anyways, that I got dressed up like this, but I forgot to wear my pants. I was wearing my shorts. Because we've got so used to sitting in front of Zoom and not actually having a conversation, looking at each other's expressions, that it really doesn't sort of seem plausible that you would have to get all dressed up, wear your shoes, and get out of the house to have a conversation with someone. So thank you, FIND, for hosting this panel. I think this is a welcome move and a wonderful event. Let me start first by actually introducing the issue at hand. We've been speaking and hearing about atmanirbharta and self-reliance for a very long time now in India. But what does it really mean? Because over the last 2 years, we've seen extreme suffering, but we've also seen extreme resilience. Many of us have been involved in that effort for COVID-19 across the country and even globally. But many argue and believe that India is now poised to take over with its manufacturing capability and its scientific and innovation capacity to become what we call self-reliant. The question, of course, in front of us is when we think of atmanirbharta or self-reliance, it doesn't happen because we want it to happen. It happens with intent, and there are teams and teams that plan for years, people who make policy, create an ecosystem that sort of encourages and furnishes us with the background in which innovation can take place, in which opportunities exist, and most importantly, in which the infrastructure exists for people to take risks. So this is what we are going to be talking about today, that what can we learn from the pandemic? What have we learned in the last few years about our own capacity to innovate, but also what are the roadblocks? Because the intent for this panel is really not to compliment ourselves, right? There's nothing that the world had which prepared us for what happened over the last 2 years. And yet, in many ways, we've come together to fight this battle with whatever tools we had, and also those tools that we innovated with and worked with. So let me not hold you back any further from the panel, because I think you really need to hear from them. We have a star-studded panel today, and I'm going to be requesting them to join me. We have Dr. Rashmi Pimpale, CEO, Research and Innovation Circle. Dr. Pimpale is the CEO of Research and Innovation Circle of Hyderabad. Next, we have Dr. Rachna Tripathi, who is the CEO of QL Life Sciences. Dr. Taslima Sarif Syed, who is CEO and Director of CCAMP. He also heads the Discovery to Innovator Accelerator program at CCAMP. Mr. Srinivas Ramanujan, CEO, Wilgrow Innovations Foundation. He's an incubator focused on making for-profit social enterprises create impact at scale and become financially self-sustaining. And of course, I'm delighted to invite an old friend, Dr. Shishendu Mukherjee, who is a veteran in this field, who I've had the pleasure to work with. Dr. Mukherjee is a medical microbiologist. He has decades of experience, and many of us have had the privilege of working with him. And he is currently, I'm sorry, I'm not wearing my glasses. He's currently Mission Director of the Grand Challenges India and also heads the Intellectual Property, Technology Transfer and Communications Division at BIRAC. So thank you to this esteemed panel for joining us. I'm going to be joining them now on stage. With this introduction, I really want to turn first to Rashmi, because I think we've had this conversation even before, during the tea break, about, everybody talks about atmanirbharta like it's something that is going to happen. But what does atmanirbharta really mean in India's healthcare context today? And what do you think are the barriers to atmanirbharta in that sense? Because taking a product from innovation to market is a long journey. So what are we talking about in terms of barriers and conceptual framework?
Thank you, Chapel, for the kind introduction, and thank you, Fine, for giving this opportunity, for inviting for this panel, and giving this opportunity to interact with all of you and the panelists. I think coming to your question, like many other things that COVID has redefined for us, it has also brought the concept of atmanirbharta to the forefront in a very big way. Now, self-reliance in this context does not mean that we close our doors to the world. It means that we strengthen our internal capabilities to the extent that we are able to face any challenges that any external circumstances will throw at us. During the pandemic, very early stages of the pandemic, we all have gone through, we've all seen how difficult it was to even get a COVID test done and how expensive it was at that time. And this was largely because there was a very limited availability of the diagnostic tests, and more so because of the scarcity of the raw materials that go into it, the reagents and biochemicals that go into it. And there were issues like supply chain disruptions, sourcing of raw materials, and even the dearth of trained manpower to actually conduct those tests. So if we talk about barriers, I think one of the universal challenges is that the perception of each entity of the importance and relevance of the problem statement at hand, and the difference in the expectation and speed of delivery. Now, in our experience of working with research institutions and hospitals, we realize that they seek thoroughness and they seek rigor, while startups seek speed because they want to move very quickly ahead, right? And that's the gap that we are actually seeing. Now, in Hyderabad, there are close to 40 research and academic institutions which are doing some world-class research. And even if they are working on a common area, their priorities for that area may not be the same. And so are even the timelines are different. And more we are increasingly seeing that startups are coming into the space which is on the borderline of application of that research. On the other hand, there are actual practitioners like clinicians and then there are governments with different priorities. So unless we bring all of them together, the industry, academia, startups and government bodies, we cannot have a complete picture. I'll just give you an example. MedTech startups, as we know, right now is one of the largest pool of startups that are coming up. However, those startups face extreme difficulties in clinical validation, testing, prototyping, and even regulatory guidance. So hospitals come into picture here, right? And that again, bringing the private sector startups and connecting them with public sector hospitals is something that really needs to be looked at. And as data is gaining prominence in every sector, we are seeing some unique challenges when we are interacting with different stakeholders. Like the value of the data from the point of view of the users and the point of view of the owners, there is a large difference in how those two value that data. And issues like who will own the data, who will, on whose servers will the data sit, who will manage it, who will annotate it, it all comes up. And there are really no easy answers for these questions. And when it comes to actually putting the data to use for the end users, again, there are issues like, do we really keep it open for researchers or do we commercialize it? So I think these are some of the very challenging questions that come up when we are having interactions with all the different stakeholders that we work with.
Thank you so much, because I think this takes me back to 20 years ago when we were trying to work on TB diagnostics in India. And one of the challenges was data. And Dr. Mukherjee, I'm going to come to you next because you were involved in that effort. And how do you translate new innovations into new markets, questions of access and affordability? But my question to you is a little bit different. You know, we have, over the COVID-19 pandemic, seen great manufacturing capacity. We keep talking about, Bill was referring to about 60% of the world's drugs, pharmacies, vaccines. This is all great. But how do we leverage this for self-reliance? Because, you know, it becomes like self-congratulatory unless we actually can make that leap to the next level.
Thank you, Chapal. Let me thank Sanjay for the invite today and a lot of familiar faces here and great interactions. I missed the morning session, but I heard there were great interactions. So, you know, let us step back and let's not start from the COVID thing. The COVID thing, you know, literally helped us to learn a lot. But, you know, the process of what we call the atmanirbharta at least started almost a decade back, if you see. And I always give an example of, you know, farming of innovations and hunting of innovations. You know, the government established a lot of mechanisms in place, which my colleague just mentioned, you know, to enable the innovation ecosystem in this country. And, you know, BIRAC is one such example, to name a few, that, you know, we at BIRAC not only fund but enable the innovation ecosystem and through various mechanisms. And one such mechanism is to establish a network of incubators, literally to encourage the startup culture in India, beginning from, you know, college, post-graduation, PhD levels, to really look at innovation. And for that, a facilitation mechanism was established by the government, first in terms of funding, where funding is very critical, and there are a lot of mechanisms by which, you know, fund innovation can be ignited. But 60% is funding, what I think. But remaining 40% is, you know, to plan your business plan, exit strategy, regulatory challenges, IP challenges. That enabling ecosystem was also established. So that created, as she rightly mentioned, the major chunk comes from medtech innovation ecosystem, but because I also like to fund those because they are low-hanging fruits. Diagnostic and medtech are very low-hanging fruit. You could know in 2 years' time whether your program works or it fails. So, but then we need to really work on the other elements like drug discovery and vaccines and other things. My colleague Kavita is sitting here, and if you listen to her when we used to work together in in the initial COVID days, I think Kavita used to sleep only 2-3 hours a day, and throughout the day night we all used to work talking at 12 o'clock in the night. So I think that really so this platform which was established literally helped us to address a lot of challenges when the pandemic started coming in. And there the concept of atmanirbharta really played in. I'll tell you, because if you see 29 Jan or something like that, it was, the exact date is pandemic was declared, India started gearing up. The first thing we required was, the sanitizers, the thermal sensors, ventilators, PPE kits, masks. I think, and it came from maximum our startups. And they literally came up to the occasion, produced that. We were running short of things, there were mechanisms were made, established, things like that. Following that was the diagnostics. And our Indian companies literally, Sriram is sitting here, his company, my labs and other companies literally came to the occasion. There was initially funding provided by us and the organizations to support that and literally hand-holded them to get the clearances and other things. So that came up. And then the vaccine story started. And then the vaccine story started, the mission COVID Suraksha, and I have the privilege to work with that as well. Kavita was there. And then the vaccine story started, and I don't have to tell you the story, but we delivered, on the mission COVID Suraksha, 5 vaccines came out. But, these vaccine stories is not just only we can say that the innovation, the background, and I'm nice to see Kayla here, and Kayla and we work together under the Grand Challenges program. They have literally supported a lot of diagnostics vans, the clinical trial sites, the bioassay labs. I think we work with Kayla a lot on that. And so, not only the vaccine development, but the infrastructure to support vaccine and diagnostic validation was established well in advance, that you have cohorts where the vaccine gets tested, the immunological animal studies are done. So I think this platform, which was enabled by the government, literally helped to take the innovation from literally the bench. We had strong scientific capabilities. But then these enabling mechanisms, which were established by the system, and it was really received well by the scientific community, by the companies, by the startups, by the vaccine manufacturers, diagnostic manufacturers, really transformed. And right now you see, we are quite well established into it. So the policy thrust was basically to become an enabler. To become an enabler and literally handhold the innovations to take from the bench to the community. That was the basic, and that literally led to our Atmanirbharta. Now the next leap is, we have these platforms which have been developed. Ultimately we talk of new pandemics, God willing nothing should come, but we should be geared up for that. These platforms might be used for other vaccine and infectious disease vaccine candidates. These diagnostic tools, Sriram, we are discussing, can we use this for some other diagnostics as well? We can do it very quickly now. So I think this was really a big learning from them.
I think it's also very important that you mentioned that how do we take the learnings from this pandemic to spur innovation, because I think we've been so absorbed in this pandemic that we are not really thinking of it. We are just thinking of it as a response on a daily basis. Dr. Said, let me turn to you, because you're an incubator in a sense. And we've heard the policy perspective, we've heard the historical perspective, both of which are very valuable because they provide us a grounding. But let me ask you a simple question, like you're an incubator, you work with innovators. Now, what is the startup scene like? And what are the challenges and opportunities, right? Like hardcore, on the ground, what is the reality?
So thank you, Mr. Chappell. And hello everyone, good afternoon. Great to be here. Thanks, fine team, for having me here. But I think it's a very important, larger topic, and I was just, while I was preparing myself, I thought about a very interesting example that I had myself, early childhood. Early childhood, being just like every other kid on the block, a cricket fanatic, wanted to watch cricket all the time and play all the time. Possibly early years, in early 80s, we didn't have television at home. So but there was television next door to my best friend's place, right? And then I would go home, knock the door, they are having dinner, doesn't matter. I want to watch television because the cricket game is going on. The analogy I'm bringing on is actually that is dependency on your neighbor. And then there is self-reliance when dad and mom got the television home. The idea was not to say that why, but when we need it, when it is required, if there is a requirement, how about having capabilities at our home? So that possibly you're not in a juncture that you are possibly, unable to meet your requirements. And that's what a nation needs to have the capability to respond to national challenges. Healthcare, education, these are absolutely crucial to have self-reliance. So while you collaborate, while you work, but there has to be basic capabilities that we saw, all of us saw, that is required. So I think self-reliance, which in Hindi would go as atmanirbharta, is actually coming from that thought process, is not to say that we are not working together, but I say, can we have something so we are not stranded? And to be honest, we all know that we kind of were stranded, in March 2020. We kind of were stranded, let's accept that. I was coming for meetings here till early March and hoping that, just like possibly happened in Europe and US, we would not have such a, real issue here. I'm really hoping, there was a BCG counter thought, everything. We were hoping against whatever it is. But come late March, we started having numbers going up, and then we had a lockdown. The reason I'm saying it to you all is actually there is late March, all of us who are in the healthcare system realized that we did not have resources to fight this pandemic of COVID. And the simple basic concept was that we didn't have the enough capabilities and capacity to actually respond to it for these resources. And there are two larger examples of work that I wanted to share today with you, if time allows, but please stop me. Kind of have got into the habit of continuing my thoughts, so please stop me wherever you think it's right. But two larger things we realized sitting in Bangalore at CCAM. One, of course, in conversations with Dr. Swaroop, former Secretary DBT, Kiran Majumdar at Biocon, a larger thought emerged that there is absolutely dearth of testing, which was the center pillar of the, preventing the further progress, ensuring the early therapeutic help happens to be. It was a run. We didn't have it. We were calling people from companies to say, can you get in one flight for 5 lakh, 500,000 things per month? Really, this was the April discussion, April and May discussion. I had a discussion with Dr. Mukherjee on that. Because the television was in next door's house. Television was not in our house. What idea was that can we now see whether we have enough money, enough capabilities to build television in our house, because right now we need to watch the TV. We need to watch. And that was an effort which we actually worked upon to say that there are enough players who are in the surroundings to create those diagnostics, enough players. And we actually launched a program to assess which are those players, where do they each stand, and we realized that they are doing well. There are 2 points that they need to be helped on. A, the quality of the reagents and kits for at the gold standard level. Second, doing it at the scale. And how do we help them? So with many other collaborators, we launched a program which we call as INDEX, which is short form of Indigenization of Diagnostics, with a very ambitious, crazy ambitious goal saying that we will build one capacity in May, June, we said, we'll build capacity for RT-PCR tests, 1 million tests per day. That was very ambitious at that time. And Rockefeller Foundation came in and supported that. This was driven under the guidance of the PSA and supported by many organizations, including Rich was a part of that program, NCBS, INSTEM, CCAB, ISA Pune, were COEs. Long story short, I think what we realized is that by doing this hub and spoke model, getting 200 odd companies who are in the surroundings of building that, helping them for the quality and scale up, we actually, in July 21, we actually announced that we have reached 950,000 RT-PCR from India, from that cohort. And that was stunning. That is availability. But the more important outcome of that, and if I may say so, the amount of cost that we had it around, which was around, I think, $60 in May, June 2020. In June, it actually came down to less than $5. That and making India one of the most affordable RT-PCR in the world. That is amazing. That was really this movement from a tentative diagnostic ecosystem to a self-confident diagnostic system, not only for today but future, is actually something that we should look at and see how we can sustain that. So that is one important thing that we have. And I would say that we have to look at it from ecosystem perspective and not from a objective perspective for short term. And that is the goal in terms of self-reliance. We should look at capability to respond to national need going forward in crucial sectors like healthcare is actually absolutely important, and we must work on it. I'll not say the second example because I've taken enough time. I'll come back to it. Thank you.
Back to that. But I think these are three very critical points that I want to take to you, Dr. Tripathi. One is about looking at the role of diagnostic manufacturers, because this session is titled Lessons from the Pandemic, right? So how did the diagnostic manufacturers respond to this crisis? And I also wanted to specifically look at, what have we learned from India's experience in expanding or responding to this crisis, particularly in the area of diagnostics. Because like we were discussing earlier, we keep talking about vaccines and medicines and how we're a leader in that. But what about this issue? What is your understanding? What are our learnings from this?
First of all, good afternoon, everyone. And thank you for giving me this opportunity to present our point of view here. Yes, I cannot forget those days, the COVID days. I remember very well, it was December end, and we realized that it won't take much time when the COVID comes from China to India. The COVID-19 genome sequence was released. Even primers and probes were released, which were tested with actual virus, which was available in Germany or China. So we quickly analyzed the genome, synthesized the probes and primers, because we were doing molecular diagnostics. We are in this area for quite a long time. We generated the synthetic controls. Everything was done, if you say, from the development perspective. But the biggest challenge was manufacturing. Because vaccine industry had seen that the numbers are huge, but for diagnostics, numbers was never so huge. So nobody had the capacity to manufacture. Even if we know that how to do it, we didn't have the things available. The manpower, as everyone is saying, for the quality manufacturing, it is required good quality of manpower, which is very, very limited. And the second thing, when we start doing it step by step, I might take a little bit more time, but I really want to put it that yes, we used to buy probes and primers from outside. Yes, luckily we were manufacturing just a year before we took a grant from BIRAC, and we established the scale up of the enzymes. So we were ready with the enzymes. But we never thought that probe and primers will be required in huge quantities and we need to establish our own facility. But at the moment when you really need it, we used to buy from Belgium. They said, no, we are full with our capacity. We can't supply you. We are doing it for our country. You go back, okay, you have only one manufacturer in Bangalore. That's also a multinational company. And they manufacture only limited variety of those things. So we had to design our test. So we use only those dyes which were available in the Bangalore. But again, they were overloaded because from all over India they had requests, and they were also dependent outside for their ancillary reagents. So we were stuck, okay? Then again we approached BIRAC that yes, we want to establish this facility quickly. We do have enzymes available and we can do it. We got the grant, and within 1.5 or 2 months, we established the probe primer manufacturing facility. We got the people who were experts into it. We gathered the chemist, we gathered the biologist, and we established probe primer manufacturing for all the varieties so we can manufacture the test which is like what you are getting from international market with the different colors, and I won't go into the intricacies. Okay, somehow we managed it. Still, we were struggling for the raw material required for it, but we established some contracts and we started getting it. The next challenge was, okay, kit is ready. We were supplying, we supplied around 5 crore tests to the different state governments and people, but plastic vials. Because for our kind of product, the quality of the container is very, very important, because you lose the stability, you lose the performance if the vial is not good. We used to buy earlier from Canada because it was a small quantity. We started hunting, and for surprise, we don't have the medical grade plastic manufacturing in the country. This is something very, very simple, but your bulk reagents are ready and you don't have a vials to supply it. Whatever vials you are getting are not of the quality what you want. Several times you try to adjust, but it is a compromise. Then we went back, hunted, okay, we went to our engineer friends, we went to plastic manufacturers, and 2-3 of us again made the mold and started manufacturing those vials. In 2-3 months, again, we were ready with the vials. And I can say proudly that during the pandemic, it was a pressure. It was like people were leaving that, no, we don't want to be. Because when you are manufacturing the test, you also get the responsibility. This RT-PCR test was never so popular. And it comes with a lot of intricacies also, because it's not a result. All the tests are not sample in, result out. So you need to train people. If any problem is coming, you need to, at least initially, you need to go there. So 1 or 2 people, 3 people started resigning that, no, we cannot go. And that too, you need to go to the hospitals, which are hub of infections. So we ourselves started traveling. Take our car, stop in between, sleep inside the car, reach in 1 or 2 days to the hospitals, to the different states, and slowly we developed online training modules and videos which we could send. So it was, yes, there was a lot of pressure, but it was an interesting journey. We learned a lot, and ultimately looking at everything, what I feel that a good manufacturing ecosystem is required. And rather than going at very high-fi level, we need to set right our ABC.
I mean, I think these are very important points, because what you're pointing to is the fact that you can have the innovation, but you can sometimes even something like a plastic vial can stop you from delivering that innovation to the grassroots level. And what is also important is that we are planning piecemeal, right? You have the innovation ready, but you don't have the manufacturing capacity. You have the manufacturing capacity, but you don't have the capacity to train, and then you're stuck. So this is a broader, but this is also broader, Srinivas, if I can get you in, this is also a broader startup question, right? This is something that plagues startups in India all the time. I have X, but I don't know how to get it validated. I have Y, but I don't know who will manufacture it. You work with a diversity of startups in a sense. And what do you think are certain kinds of technologies and business models that have caught the post-COVID, and particularly during COVID, the attention of startups in India? And I'm referring now primarily to folks who work on health issues.
Right, thank you. And I also had the luxury of hindsight going last, hearing the folks before me and in this panel. The important point is I'm not an expert like all of you folks here, and Wilgrow, while has some technical expertise, we are more, I think we have a lot more competence in commercialization and in helping social enterprises get into market and build partnerships. And this pandemic, honestly, was, like I think someone else mentioned, was an exciting time for many people, because I think it renewed the love between allies. And they also mentioned that this love should last after the pandemic. And another thing, the pandemic also brought something into sharp focus. It was a lens which got everyone to look at infectious diseases. I mean, you could be talking about COVID today. We spoke a lot about TB. But at the same time, there's a whole bunch of other diseases which have gone unnoticed, where the burden's gone up, and it's likely that's going to be India's future health problem. For example, diabetes, cardiovascular diseases, all of them still need diagnostics. Now, and they are not, I think they've already reached epidemic proportions in this country. Add to it climate change, and I know a few months ago they discovered cases of anthrax in somewhere in Siberia, right? I mean, we all thought anthrax is eradicated. So this is the, if you will, the palette that we're looking at. In some ways, this is what we're going to face going forward. And honestly, in India, and I think we've got to unpack what public sector, what private sector is. I mean, that's my personal view. That's what we look at Wilgo. Like, for example, Dr. Downs, when he spoke about labs and the standards there, I think that's one piece of private sector. That's, in my mind, infrastructure, right? The end delivery. There's a whole bunch of folks who are building generics. There's a whole bunch of folks building equipment. And all of these have different levels to move them. And there's a state and there's policy. I think today, I mean, folks like Bairak, Dr. Mukherjee, you are here, right? And the grand challenges, or what DBT does, is phenomenal. The amount of capital, the amount of focus that they bring towards technology is great. But then, the chain to commercialization is really long. There, I think there are lots of gaps. So while capital comes in, I could always argue that the government is the largest funder today of innovation and technology in this country. I would also argue private sector, when I unpack it, non-infrastructure, a lot more risk capital is conspicuously absent in this country. There are pretty much no VCs. I mean, you could talk about India booming in venture capital. You could talk about the number of billions of dollars in unicorns which have happened in ag tech and what have you. But all of it has pretty much gone into one model, which is market linkages. Right? You could speak about 1mg and PharmEasy, but they are in effect folks who are shipping medication to your homes. It's the same model as an Amazon or a Flipkart, but it's a medication. Now, categorizing that as innovation in healthcare and money going into healthcare, I don't think is right. It's sort of disingenuous. If you start looking at innovation in diagnostics, screening for cancer, breast cancer, cervical cancer, and even in TB, in malaria, dengue, chikungunya, and if this can get into PHCs far cheaper and also in a way that unskilled folks can use it. Like, for example, I think in the previous panel speaking about how when folks were out of the lab taking sputum tests, someone else stepped up and did some other test. So in fact, there are new jobs being created, new skills that are required. There are ideas with startups, right? There are lots of them. But then after proof of validation, most of them struggle. They're just like zombies in this country. So we have them registered, but very, very few commercialized. So we've been, and I talk this with a lot of passion because this is an area that we've been trying to sort of catalyze. How do we make public-private partnerships happen? And I know Dr. Poti spoke about the 300 crores which has gone in from private sector, but mind you, almost all of it was CSR money, mandated spends that the government demands. How much of that money was actual marketing budgets or part of R&D of business money from private sector? I would suspect very little. So it's great to have one-off private sector spends, but are you committing to a partnership? Are you signing a business deal saying, I'm going to put it in my distribution network, I'm going to add it to my product portfolio? I think we're still some way away.
I mean, I think it's also an interesting point, right, Srinivas, because as, I hate to say this, but as Indians, we are always accused of being non-risk takers, right? So what you're saying is the government still remains the primary funder of innovation in this country, in that sense, for startups. And when you look at medical or health issues, it's possibly the only largest funder that we have today. And that sort of also then begs the question that you're raising. I mean, Rashmi, I want to take this to you. That why is then if the government is the biggest supporter, and it's the job of the government, and the government has, as Dr. Mukherjee pointed out, done some incredible work in the last decade, how is the regulatory environment different? Why is the product to market period difficult or challenging? And I mean, we've done a very good job for that with vaccines, as we've seen. Have we made it more difficult for diagnosis? What would you say to that? What do you think are the important changes that need to happen in the regulatory environment to cultivate that ecosystem and from product to market kind of travel?
So one of the hallmarks of the regulatory approval processes for pharmaceuticals is the lengthy periods of time and the immense cost that comes with conducting these trials. Now, diagnostics fare relatively better here, but they have their unique set of challenges. While the pharmaceuticals regulatory approval environment is very well understood and established, this space in diagnostics is constantly evolving because we are seeing a lot of new technologies, lot of innovations which are based on digital technologies that are emerging. So I think simplifying the regulatory pathway for startups and MSMEs is one of the key elements for reducing the hurdles. During COVID, we saw that how fast tracking of regulatory approval processes for COVID tests, it helped a large number of MSMEs and startups to upgrade their product, to scale up their product. So that is the kind of momentum we now want to continue to build, because that I think is the single biggest hurdle that that the startups or MSMEs face right now. One of the other things, I think some national level interventions in two areas that need to be done. One is the digitization of patient data, and I think that is being taken care of in some form by introduction of this initiative of the digital health ID. And in that, participation of public hospitals is going to be of immense value, because the kind of patients and the sheer volume of patients that they see on a daily basis cannot match any private hospitals. In one of the public hospitals that we had visited about 2 years ago in Hyderabad, one of the mainstream public hospitals, the dean there was so passionate and to take up newer innovations, but he said that we are so overworked. He gave us some stats that we have the capability of seeing 600 patients per day, but we end up seeing 2,600 patients per day. So that is the kind of workload and burden that they have. So I think getting a buy-in, getting participation from public hospitals is also a key. And another important link to that would be setting up high-quality biobanks, where tissue and blood samples can be stored at favorable conditions, which can be used by researchers, scientists, the clinicians themselves, startups, for fast tracking the regulatory approval processes for their products. And
sorry, yeah, please.
Yeah, and I think that's where the role of a cluster comes into picture, wherein some entity who can bridge that gap, who can bring everybody together, who may not have the avenues or bandwidth or even an inclination to start the conversations with each other.
No, thank you. I was actually going to ask you just that, because that is the role of a cluster, isn't it? Because only a cluster can achieve all this for a private sector startup. They are never going to be able to work through the bureaucratic paperwork, ever going to get access to data, and no innovation is going to be possible without data. I mean, however good you think it is. And it has to actually also work in the public sector. Because if it doesn't work in India, in the public sector, where does it really work, right? Because that's where the largest number of patients are seen in a way. So Dr. Mukherjee, I also want to turn to you and ask the slightly trickier question about, and I've already been warned that our time is getting up, but I'm going to still, because I think this is an important issue and you've worked on this. The issue of technology transfer, right? And what are the potential solutions around it? Because we saw that that can be a serious roadblock, not just during this pandemic, but even previously.
Okay, before I answer your question, I'll just add to what Rashmi said. The regulatory pathways for our startups is, essentially they need to have a place where they should go and somebody should handhold them. What is the road ahead? So looking at that and under the instructions from Member Health Niti, BIRAC established through DBTs and that time Dr. Surup and Tasneem knows well about it, is that first hub, we call it Open Darbar, on first Friday of every month from 4 to 6. Anybody can walk in, and there are, initially we have to have it physically, but right now it is online. The regulator sits there from DCGI's office, from the ICMR, from Bureau of Indian Standards, from Indian Institute of NIB, Biologicals, DBT, and GEM, ultimately who buys it. So they all sit there, and they literally handhold our startups to tell us that this is your next step, this is how you should do, and if you get stuck up, they help it. So that is one thing. Regarding the challenges in technology transfer, which you pointed out, I'll give you a very short answer as lunch is nearing. So what the idea what BIRAC thought, and this was a global national discussion we had, the incubators which has been created by us. It is right now the 7-star incubators, which Tasneem leads one of them, and these nearing 70 bionests, which has been, technology transfer is a challenge, and what Dr. Rodriguez also said, that the collaboration between academia and industry is very, very essential. The science needs to be driven by academia, the commercialization, the commercial exit has to be done by the industry. And between those, the technology transfer has to. So initially when the innovation starts, if this partnership is put forth, that will be really step forward to. Under the National Biopharma Mission, we have literally looked at this gap very, very strongly. We have now established 7 TPOs in India in the academic settings. The idea is to literally look at the academic environment, connect them to the industry, not only connect, but build capacities of technology management between the startups, the academia, to take the technologies from one level to another. There has been a discussion, it is because we are very, very iterative, we learn from various processes. It is not an easy answer or easy solution to it. I always call it 360-degree innovation. Science is the key part of it. 60% is science, but 40% is the story you tell. The regulatory, the IP, the exit strategy, the marketing plan. So this all needs to be, composed together. When I do my grant writing workshops and grant cleaning, your story has to be just like a fairy tale. It should start with once upon a time and end with happily lived ever after. So this is how you have to build the concept.
I mean, this is almost like having a talented child, isn't it? Because you really have to take them by the hand and show them the way, because you really want them to succeed. It is not something you can leave to chance. It is not something you hope life will teach them. It has to happen through a very supportive system.
Handholding is absolutely essential.
Now that we are talking about the process of handholding and incubation in a sense, Dr. Said, let me turn to you and ask you. You chose under C Camp 7 startups, which sort of were innovating to sort of work around containing the virus. And how have those brought up changes in screening or monitoring and diagnosis? Very briefly, if you could tell us, because I think that also tells us what the changes are possible in the broader health system, because I think everybody is getting fidgety and hungry.
Yeah, and briefly is difficult for me, but nonetheless, let me try. But just to, I think if you just taking another, and I said there are 2 initiatives, I think you're referring to the second initiative, just about time when we realized that we didn't have resources. The first story was about diagnostics, completely. The second story was that we didn't have other resources as well. Diagnostics, respiratory support devices, preventative devices, decontamination devices, therapeutics, vaccine transport, and so on. Absolutely none, because the need was worldwide and access to those were not there. At that time, what we attempted to do is that, can we say that let's look at it in our own backyard and say that do we have startups, do we have innovators who are in the proximity of such innovations? They were doing it for something else, but now, since a lot of work has been done by government over the last 10 to 15 years of many other things, we had enough startups who were in the proximity of COVID-19 resources as well, but they were not ready. Idea was to see, can we actually do a national call to say that attract them first of all, then assess them and identify them, and see which are the ones who are absolutely, after assessment, near ready. So we did a call in April first week, and within a month we got around 1,100 innovations, 1,100 within a month, which claimed that they were near, the technology deployment ready in a way for COVID-19 across the different aspects I said. We selected 30 odd, every week 7 odd. We selected, and every Saturday morning we would do a kind of an open meeting hosted by Your Story to say these are our stars of the week, and we will put it out for everybody to come and say these are the ones that we have assessed and we think this can actually deliver on the ground if we support them. So 7, within a month we had 30. Idea was to now handhold them and understand what each one of them need. Funding, connect with the government, state government, federal government, regulatory support, industrial connect, whatever they need. Then we actually handheld them after the picking up. I'm very happy to share, and this actually goes back that you had the critical mass of near deployment ready. We actually have this innovations out of 30, 23 are in the market and in the 17 states serving them already. And that is something very, very good. What it required was to bring them on one platform, making them available to everyone, and then connect them and help them deliver what their potential was them, help them realize their potential and do that. And I think that kind of effort where, identifying the potential, helping them with the realization and delivering on the ground is something an ecosystem player like us on a national platform could do, and something that we were very happy that we could contribute to that.
I mean, this is also sort of speaking to what Rashmi said and what Dr. Mukherjee said, and also Srinivas said, that you need probably several platforms that link industry, patients, innovations, and so many other things. Let me turn to you, Dr. Tripathi, because I think this is also a forum hosted by Diagnostics NGO, and I think it's very important for us to consider some of the harder questions in diagnosis, which is, something that I would want to ask you is, what do you think, very briefly again, what are the prospects for these multi-pathogen tests that we are in India today, for instance? And molecular testing is something that you referred to earlier, and you said we've been doing that, but it's still not as widely available as we would like it to be. So what would make it widely available? If you could touch on both these points very briefly.
Yeah, with the changing environment, human body is changing. Diseases are becoming more and more complicated. You talk to any doctor, you can understand that it was much easier to treat a patient earlier than now. Patient comes with and the diabetes coming into picture, immunocompromised, so different kind of bacteria which were not, infections which were not so common are becoming common, and discrimination between the causing pathogen is becoming very, very important. So multiplexing is indeed going to be a very important testing method which we require even now, and in future the demand is going to increase for respiratory, like we were talking TB and COVID, but not only TB, COVID, RSV, parainfluenza, influenza, rhinovirus. There are several which can cause similar kind of symptoms. So yes, multiplexing is very, very important. And the second question, that to take molecular diagnostics, earlier, like molecular diagnostics started as a very fancy technology. and you require a lot of training for it, you require a lot of skills to do it. But at the same time, what is now required to simplify it, reducing the cost, simplifying it, and then making it possible that it can be done even at the primary healthcare center, or maybe a home test for certain things should be possible. But for that, as many have said, that there is a lack of funding. There are no VCs with patients. Because when you are dealing with the biology, it's like an art. If you want a good product, you need to give it time, you need to give it whatever is required to it. A good manpower, good quality reagents, enough time to understand how it's behaving and then putting it into. Diagnostics is easiest, but still it needs all this. So what is lacking right now, probably we have a lot of good scientists, we have the capability to do it, but the ecosystem is lacking.
I mean, I think all of you have made very, very relevant points. I'm going to also, because I've been requested to tell people that they can ask questions, because there have been some requests for questions. So are there any questions from the audience that we can do? Because if you are, please raise your hand and just introduce yourself. And if you wish to ask a question around to any of the speakers.
It's rather than a question, it's more of a narration, and I also wanted to just relate to a couple of things which were said. Also wanted to congratulate a couple of you who were there, who said things which were very relevant. So coming from a startup myself, being a co-founder, and by the time you work on the product and then you get it to a level where the proof of concept is done, the only thing one would in India look at is the Dr. Shishendu is the grand challenges, and that's very engaging. And it gives you a lot of confidence. So I wanted to congratulate for somebody who's just, from the technical side, come up with the product, and then to figure out how to take it to the next level. I think it's very encouraging. And we started with, applying where 200 people apply, and then come down to 50 semi-finalists, and then come down to 7 finalists. It shows, it gives you a confidence to say, yes, the product is relevant. But I would go back to what Srinivas was saying, that from the proof of concept phase to actually getting to, the product being in the market, most of the startups become zombies because, when you're bootstrapped, to get to a level of proof of concept and then go to VCs where they ask you, how much profits are being made, there's a gap. So my question basically was that from in India, and we're very rightly saying that the private sector really is not something where the funding is adequate or incubation is adequate. I wanted to ask a question to all of you, and also to Dr. Shishendu. I'm sorry to put you on the spot. Although the department is doing a great job, I wanted to understand what is being done to get this VCs to start risking rather than, being in that safe zone of funding where funding is really not required and that somebody is already making profits.
Let me take a stab at it. Sure, please. So I think in most of these markets, I think the first catalyst in many ways is the government. Right? A case in point would be digital payments. It was because of NCPI and the platform that NCPI enabled, now that everyone thinks of Paytm and PhonePe and Google Pay and so on, right? And India is probably the most innovative place when it comes to digital payments, and it was a push by the government, right, in policy. And the last month, I've begun travel, and I see a lot of encouraging signs. First, again, in that same kind of push, right? I've been speaking with folks at NITI Aayog, at DPIIT, the folks who have been making these connections happen, make things commercialize and get on. There's a lot of interest to give that push, and where they're also pulling in VCs. Yeah, so I suspect it will happen sooner rather than later. Yeah, but that's one. But the second area about startups and where I think the opportunity is if we were to follow a traditional Western-driven model of saying science first, then we are not playing to our strength. India is a leader when it comes to data sciences. Right? At the end of the day, if you want to deliver good health for all, it's more useful to give insights, right, and some action. And the cost of delivering the action or the insight should not be benchmarked to something in the West. Right? And it's ridiculously expensive cost. For example, the US. That's not something we want to replicate in India. So there's an opportunity even for startups, honestly, to start innovating beyond the box. Just don't copy what you've seen in the West, make one more model, and come back with the same cost structure. I think that imagination has to come from a whole bunch of startups. I think the government is beginning to think about it, and there is some, fresh sprouts happening there. So I think it's a matter of time overall.
Dr. Mukherjee, do you want to add to that? Because I think you're waiting to. Yeah. So I think absolutely you're right. What I said in the beginning, farming innovation, giving 50 lakhs, 100 lakhs, a crore to bring that innovation to a strong proof of concept is what you just described. That's absolutely. And we, within the system and the leadership between DBT and BIRAC and other our partners, the Gates Foundation, have really understood that. So we are trying to create programs and iterating. So I don't know whether you heard the name of a product commercialization grant which we have started. It's not actually a grant, it is a program where if you have been funded through our networks, and you are cross TRL 5+, you are given an amount which is a good amount to manufacture, create a manufacturing facility, market. So that is one element we thought to handhold what is the last mile what you described. BIRAC is created a funds of funds, sort of a venture fund with various 6-7 partners to support, to do a venture funding as well through our incubation network. I think the stream is a part of it. And then the LEAP Fund. And recently announced last week, BioAngel Fund. So, we are iterating and trying to get to that space which you have said it's a big gap. But we are trying to create that space, understand that, handhold that space. We are also learning from you all where the gap's coming in, and BIRAC has been very nice to become iterative and to understand where the gap is and handhold that. So we are trying to see that that gap is addressed. But it is a long gap, I really admit that, but we are trying to see these couple of instruments which we have created, the commercialization grant, where you have a strong, you're cross TRL 5, but you need to reach the market. The end point of that grant is market. Similarly, the other grant, the LEAP Fund, the BioAngels, the ACE Fund, the funds of funds are really hand-holding that. But there is a gap, it has to be, but we are really pushing it.
I think before we break for lunch, I wanted to invite Ms. Vinita Sethi to propose a vote of thanks. Vinita is the Senior Vice President and the Chief of Public Affairs at Apollo Hospitals. She works very actively with the industry and the government to accelerate the growth of an inclusive healthcare ecosystem and is heavily engaged with policy advocacy forums and ministries as well as the think tanks. She also engages with global stakeholders like the World Economic Forum and is also Secretary Public Affairs Forum of India. Vinita has a Master's in Economics from the Delhi School of Economics, followed by a Master's in International Relations from the International University of Japan.
Goodness, this is all a packed day we had, and with all of you experts here, my vote of thanks is redundant, to be honest. My first gratitude is to all of you for doing whatever you are doing and strengthening the healthcare. Emma, thank you for flying in and having us do this, and Sanjay's been such a pillar of support for Find in India. Bill and Dr. Sabarjeet, all of you who've come in here, I hope you have a very good stay, and thank you so much for doing this. To the rest of you here, I think you all are such experts that the only takeaways that I have, and I wish we could engage more in the kind of takeaways I have kind of heard today. I would just start with Dr. Sapna, who's not here, but then she mentioned two colors in the mask, black and red. And as we come to a close, I see many shades of gray. And fast-tracking India's atmanirbharta in healthcare is in gray too, which means there's a lot more work we need to do. There are a lot of shades of gray we need to actually look. And it was amazing that, we've done this fight, as we call it, a fight over 2 years for, making our systems. Initially, I would say, let me divide it into two phases. The fight for, making our population safe against the pandemic, which is still not gone. The virus is still lurking. And now as we get into building resilience is where the shades of gray start. Because building resilience is going to be a lot more tougher. And it's like when we were stuck with COVID, we were in a burning bridge trying to fix things as we were walking along. Now we at least can look back, like you said, the lessons, and start strengthening those ropes and the bridge to see if it happens, God forbid, again, what will we do? And my fear is not just another infectious disease. My fear is that we should not fail our population in the slippages we've seen this time. So the resilience would be honestly built if we can treat both the communicable and the non-communicable diseases going ahead together. If we are struck, and we will be struck by another pandemic or at least an epidemic or another infectious disease virus. So for that, you already have spelled so many things. We need an integrated healthcare system. We need an ecosystem which has 3 or 4 stakeholders working very closely with each other at all times, which includes the policy ecosystem. That's where, like Sanjay, you said, our fight is still on what is it that would work best, not just with the startups, but also with the integrated healthcare chains. You heard Dr. Dang speak of a lab that has been established over 35 years and still going through so many pain points. I come from a huge network of hospitals, and I don't even know where to start when we started a fight, and we realized there were so many fault lines, not created by COVID, but got exposed. And one of the biggest fault lines has been the healthcare workforce. How are we really going to build that capacity? Just now I got a message that government is probably going to go ahead with a public health cadre. What does that mean? We really need it, but what does that mean? Tomorrow, if there's an epidemic, will we be able to move that cadre across different parts of the country and globally to contain it immediately? So we need a lot of skills going the digital path. I mean, I know how difficult it was for our nursing and our doctors to get those 110 blue books in 30 days. I mean, we were changing protocols and we had to upskill every frontline worker had to be upskilled. So from supply chain shocks that you all have mentioned to atmanirbharta and manufacturing, there are many good steps government has taken, the PLI scheme and all, but funding and finance will always remain a very important pain point. I think when you mentioned about startups and venture capital coming in there, what will venture capital really look at? Risk, for sure, and the compared rate of interest. They want to invest in you, but if they get a better rate of interest, and if it's not social impact, capital also now chases return. So nothing comes for free and nothing is for free. So I think going ahead, we really need to work together as stakeholders, governments, multilateral agencies, bodies like FIND, the academia, and a very important point is how do we really bring all processes and products into the market rapidly, and how do we really become atmanirbhar in training ourselves also, so that we don't keep relying on an epidemic to start training ourselves. So it's an ongoing process, and with this, I have seen some very good points come. I hope FIND will prepare some steps that will come out of this, and we can, I think, share with you all, and it'll be a more deeper introspection of, and this is a very useful session, and I'm sure government will be very receptive of what comes out of this. So with this, thank you so much. Enjoy your stay, Emma, and to all of you, lunch is there, I think, in the next room. Thank you so much for being with us today.